and our webinar is accredited with 1 credit points. We got the credit point with the help of Dr. Babasaheb Ambedkar Research Society. And today's topic is endocrine diseases and its anesthesia implications. So we'll begin. I request Dr. Vasanti, President AAA, to give welcome address.
Thank you, Supriya. Good evening to one and all. I, Dr. Vasanti Kelkar Sasturkar, President of Association of Anesthesiologists Aurangabad, that is AAA, welcome you all in today's online CME on endocrine diseases and their anesthetic implications. This CME is jointly organized by AAA and Society of Anesthesiologists Maharashtra State, that is SAMS. AAA came into existence in 2021 during COVID period. I had the honor of being Secretary of ISA Aurangabad City Branch at that time. Not many members have contributed to the progress of AA since its inception. A special mention to Dr. Sangeeta Deshpande, Dr. Sujata Jine and their team, who worked tirelessly during their tenure as AA office bearers to take the association to new heights. Today, there will be a digital inauguration and launching of our new AAA logo in the auspicious hands of our own Dr. Balaji Asegavkar, who is currently President of SAMS, and in presence of Dr. Rajesh Takadpalle, Secretary of SAMS. It is really a proud moment for us. This will be a very short program followed by the most awaited academic sessions. After successful organization of CME on neuraxial blocks, this is the second CME we are organizing in association with SAMS. Today, the stalwart faculty will be discussing about two most common endocrine disorders, that is diabetes and thyroid disorders. In current settings in India, incidence of diabetes and thyroid disorders is increasing exponentially, especially diabetes is reaching epidemic proportion with its associated multi-organ involvement. Quite a few of these patients routinely come for surgery. These surgeries may be either routine or emergency surgeries. So every anesthesiologist must be aware of anesthetic implications of these disorders for successfully managing the patients in the perioperative period. I am sure today's CME will help in sorting out the confusion in our minds, if any, about management of patients with diabetes and thyroid dysfunction. Without wasting much time, I hand over the mic to Dr. Supriya for further proceedings. Thanks.
Thank you, Vasanti. Now we will move to the most awaited and prestigious moment for all AA members, that is inauguration of our AA logo. I request Dr. Balaji Asegavkar sir, President of SAMS, to launch our AA logo and give his greetings.
First, I will launch the AA logo.
तो बालाजी याला साऊंड नाही आहे का?
साऊंड आहे.
ऐकू येत नाहीये. तिकडनं एनेबल करायला लागतो झूम मधनं.
I congratulate AA for such a wonderful logo, and it's really a pride privilege for me to inaugurate a logo for Association of Anesthesiologists Aurangabad. You know, Aurangabad is my mother branch and from which I work. So it's really a very pride privilege for me to launch this logo. Aurangabad city branch has done a phenomenal work recently in last tenure of Dr. Sangeeta Deshpande madam and Dr. Sujata. They have done a very phenomenal work, and this work is continued under the leadership of Dr. Vasanti Madam and Dr. Supriya Madam. I wish them best wishes for the future, and I offer all the help from state so that they can perform even better. Having your own website and logo itself is a very big achievement for any city branch. So I appreciate your efforts in this area, and I wish you a very best of luck for the future. Thank you very much.
Thank you so much, sir. Your support is most important for all of us, and it is there always, we all know. Rajesh Sagadpalli sir has joined.
I think he has not joined.
He is not joined.
Mhm.
Okay. This A symbol is nice blend of Association of Anesthesiologists symbol of Chhatrapati Sambhaji Nagar, and symbol of anesthesia. So you must have seen in that logo that is Padma Pani, symbol of Chhatrapati Sambhaji Nagar, that is Ajanta Caves unique feature. Then AAA letters in that, and our armamentarium, that is USG Pro. So it is a nice blend of all of three. So I especially thank Dr. Pramod sir for taking efforts in making this logo, and also all AA members for giving the feedback to make this happen. So we'll move towards our academic sessions. Our first topic is diabetes mellitus, and we all know it is such a vast topic, and we face this enemy day in and day out. So it is rightly said that anesthesiologists are the preoperative physicians. We have to optimize our patient condition preoperatively and maintain it intraoperatively as well as postoperatively. But sometimes we get confused what to follow and what not to follow. So maintain this perioperative fitness. We have with us a renowned faculty, Dr. Mangesh Tiwaskar sir, a physician and diabetologist from Mumbai. I request Dr. Pramod sir to introduce Tiwaskar sir and lead the session.
Okay. Thank you, Supriya Madam. Good evening, ladies and gentlemen. It's my privilege to introduce the legend in the field of medicine, and particularly in the diabetes, the esteemed Dr. Mangesh Tiwaskar sir. Sir has achieved numerous accolades throughout his career, starting from the gold medals in the various subjects in the MBBS and also the gold medal in the MD medicine. He has pursued many fellowships from the prestigious institutes around the world, including Royal College of Physicians in London, Ireland, Glasgow, and Edinburgh, as well as fellowships in American College of Physicians, fellowships in Geriatric Society of India, fellowships in Diabetic in India. He has also done a diploma in advanced diabetology at Denmark. Currently, Dr. Tiwaskar sir is a consultant physician and diabetologist at Dahisar, Mumbai. He is editor-in-chief of Journal of Association of Physicians of India, JAPI. Sir was a former General Secretary of API, ICP, and PRF also. Sir was a former advisory committee member of American College of Physicians, Indian chapter. Sir is a guest editor to Insulite Journal and World Journal of Anemia. Sir is the editorial board and International Journal of Diabetes. Sir has more than 100 national and international publications on his name. We indeed fortunate to have such a multifaceted personality to grace our platform today. I kindly request Dr. Tiwaskar sir to share his vast knowledge and experience in the field of diabetes with us. Sir is going to discuss about the maintaining perioperative euglycemia, that is sweetness, that is about the oral hypoglycemic agents and insulin. Over to you, sir.
Wow, thank you. Thank you very much, and good evening, everybody. I hope I am visible and audible.
Yes, sir.
Thank you, Dr. Pramod, for those wonderful, wonderful words of introduction. I am really touched, and I bring greetings to all of you from the city of joy, that is Mumbai, the city of success, that is Mumbai. But my roots go to Aurangabad, actually. And I still have my golden memories of being there as a child, studying in Saraswati Bhuvan Vidyalaya, and my father being the professor of biochemistry in Ghati. I had an opportunity to stay in Begumpura for some time. Then I was staying at Kotla Panni, and I had still fantastic and phenomenal friends like Dr. Ramesh Satarkar and all these people staying there and practicing there. Also, Balaji, I know him very well, so I must compliment him for giving me this wonderful opportunity. And Dr. Supriya, I understand and really respect your hard work and the efforts that you have put in. Now, friends, in next 20 minutes or time or so, it's a little challenging for me, but what I'm trying to probably discuss with you, I'll be discussing with you, is a case which my wife insisted that I should be discussing. So I cannot disobey my wife because I have some more lives to, some more years to my life. So this is the case that she shot at me. A 57 years old male, moderately built, diabetic on OHA, comes for an emergency excision and probably debridement of a bad carbuncle. On the investigations, you can see that his counts are high, the sugars are sky high, creatinine is borderline. ECG shows left ventricular hypertrophy, confirming the cardiomegaly on the chest X-ray. Now she has shot so many questions at me. Should we wait, or should sugar to come down below 200, or shall we take it? If the patient is conscious, are there any perioperative guidelines which will definitely suggest that yes, the mortality and morbidity is less when the sugars are below 200? Can this patient be in decay, and how would I know about it? If at all it is decay and inadvertently, if I induce him or her, will complications occur? What about electrolytes? Do we need to test for urine ketones? Many places dipsticks are not available. Electrolytes cannot be done easily. So what should we do, especially in the private practice? What about the potassium, the electrolytes, the sodium? Are there any possibilities of the cardiac arrhythmias or ECG changes? What level of ketones you should be bothered about? Is ABG mandatory? And so on and so forth. And I was really impressed by her because I think these are what the questions that must be haunting all of you being an anesthetist. And as probably Dr. Balaji and Dr. Supriya and even Dr. Kedkar has beautifully said that, diabetes is not one area where only physicians or diabetologists, they will come into the play as far as the practice in India goes. We all are aware that now with the latest ICMR INDIVE 17 paper got published last year, defying the IDF data, we now know that more than 110 million diabetics inhabited in our country. And if you combine the number of diabetics in India and China, you would be really surprised to know that almost 2/3 of the global diabetes population inhabits only in these two countries. Now we have surpassed China as far as the population is concerned. And soon we are going to surpass them as far as the number of diabetics are concerned. So friends, let us discuss about diabetes and anesthesia requiring procedures. What are the precautions that you would be seeing? And I will try to be more practical. And this is my disclosure that this presentation is based on the international guidelines as well as the RSSDI Endocrine Society of India guidelines, where I had an opportunity to work, where in 2017, for the first time, we thought of coming out with clear guidelines as far as the intraoperative or perioperative diabetes care is concerned. And I also referred to a beautiful, article which was published in British Journal of Anesthesiology. And this was in 2023 last year. And this was a wonderful article. And I would recommend all of you to go through this article. So to me, whenever there is an hyperglycemia and anesthesia requiring procedure is concerned, reminds me of this 2006 National Geographic picture, where a 20-feet shark is approaching a 4-feet kayak in the middle of nowhere. Now that is exactly what when your patients are likely to face when suddenly an anesthesia requiring procedure comes into their life, being uncontrolled diabetics. So we'll just have the few points which you are seeing on the screen to be discussed today in my short talk. Always remember that hyperglycemia and hospitalization or the anesthesia requiring procedures are intertwined dragons. What do you mean by that? That means that one affects the other significantly. So always remember that. Do not ever forget to ask for the blood glucose estimation. Now, most of you are doing that. I am more than sure about it. But then how do you interpret it? If the patient is coming to your hospital for the first time, he is seeing an anesthetist for the first time, you do not have any medical clear history of this patient, comes at the admission with the fasting of 126 and a random of 200 and more. How would you know whether he or she is previously diagnosed, previously underdiagnosed or not diagnosed, or is it stress hyperglycemia? The simple answer is look at the HbA1c. A1c is mandatory after you have checked the blood glucose levels. Always find out what is the state of A1c. Not only if the patient is diabetic, but generally it has to be a mandatory investigation just before taking patient for surgery, because it will surely help you in differentiating the newly diagnosed versus stress hyperglycemia. You will decide about how are you going to manage the patient perioperatively, and also will help your surgeons, your physicians, your diabetologists to design the optimal regimen for the perioperative care as well as the discharge. Now let's understand in brief what are the drugs that we commonly use, being the physician diabetologist practicing. And now today is an IPL time, so I'll use those IPL terminologies to describe our drugs. Franchisee players, priceless, are human insulins, analog insulins, and premixed insulins. And I'm going to show you what are these different insulins are. Then there are veterans. Veterans are the established players like sulfonylureas, long time in the game. Biguanides, metformin, long time in the game. Working hard to be in are thiazolidinediones or pioglitazone. Game changers, the new babies or the recent additions to the armamentarium, GLP-1 receptor agonists, DPP-4 inhibitors, and SGLT2 inhibitors. And there are a few side watchers, bench warmers like alpha glucosidase inhibitors, greenides, imiglamin, which are all new drugs. Now, friends, these are all different insulin preparations which are available. I know you must be seeing them day in and day out, but more with the brand names. So I'll quickly tell you about the brand names. Ultrafast is 5-ASP. That means that action starts very quickly. The peak action is within 10 to 20 minutes, and the action ends at the end of around 1.5 hours. And it is available by the brand name of 5-ASP only, or also in some places as Novolog. Then there are short-acting insulins, or the analog insulins, are also called as rapid-acting insulin analogs. They are Lispro, Aspart, and Glulysin. Now, these three insulins are available by the name of, number one is that Novorapid, or Huminsulin, or Humulog, and Glulysin is very, very, very rarely used. Then we do have the regular insulin like Human Actrapid. NPH is not used nowadays, but still in probably the remote places, some places in Aurangabad, I am not sure about it, whether NPH is used. Detimir is available as Levimir, and now the rest of the four are the long-acting insulins or the long-acting insulin analogs. Detimir is available as Levimir. The advantage of this insulin is this can be given twice in a day because it has got a short half-life of around 6 to 8 hours, and the action lasts for around 16 to 20 hours. So this insulin is the only insulin, which is a basal insulin, can be easily administered twice in a day. Then we have got standard Glargine U100. Commonly, the most standard name for this insulin is Lantus or Glaritus, or now there are biosimilar insulins, which are also available in the different names. You can ask your physician or diabetologist for the help if at all some patients come with these prescriptions. Then there is injection Degludec. It's truly a long-acting drug where the half-life is technically 48 hours or more. The effect lasts for 48 to 72 hours, and the action starts within half an hour. It is available in by the name of Tresiba. And then Glargine U300. Remember that there are two different Glargines. Glargine U100, that is regular Lantus, or a concentrated Glargine, that is called as Glargine U300. This is available by the name of Tresiba, and this is available for the use where its half-life is around 24 to 30 hours. Understand that rapid-acting analogs and regular human insulins have similar action profile when they are injected intravenously. So don't worry about it. So all the rapid acting analog insulins or even your human actrapid will have the similar time action profile when you use them intravenously. Now understand, nearly 50%, 20 to 50% of diabetic patients are going to require anesthesia in some form or the other in their lifetime. But the challenge is that it induces a lot of excessive catabolism. It increases the basal metabolic rate, which will ultimately lead to more fat and protein breakdown. The glycemic control will worsen, and starvation adds to the challenge. Also, you must all remember that all type 1 diabetics and long-standing type 2 diabetics, which are more than 10 years of diagnosis, should be treated as type 1 diabetics because they do not have the adequate endogenous insulin secreting capacity, which will help you to alleviate the challenge of hyperglycemia, hyperosmolar state, ketosis, or excessive proteolysis. So how will you manage them? Remember that preoperative evaluation is mandatory, not by physicians, but also by the anesthetist, because that will definitely offer you an opportunity to access the therapeutic effectiveness and the presence of complications. So what are the things that you generally assess? We are all aware about it. I will not go into the details about it, but do not miss on any of these investigations, including an ECG, including an EPO, and in some rare cases, the treadmill test needs to be done. And also look in the eyes, because retinopathy can tell you a lot of information as far as the vascular health of the patient is concerned. Always remember that there are few determinants of the management plan which you should not be missing on. Find out what type of diabetes the patient has. What was the previous treatment regimen that the patient was on? Which drugs the patient was on? What is the current metabolic status? Whether the patient looks dehydrated, whether the patient looks decompensated. Does he have any additional vascular challenge? And also find out whether the surgery is elective surgery or an emergency surgery, major surgery or minor surgery. Now, to me, being a physician, I understand that major surgery, where probably the patient has to stay nil orally for more than 24 hours. In diabetics, there is another concerning area which you all should be aware about, that is neuropathy. Whether it is the peripheral neuropathy, where probably you would be, be a little careful while giving regional anesthesias, or autonomous neuropathies, because autonomic neuropathies can cause delayed gastric emptying, which will increase the chances of PONV, which will worsen the blood pressure fluctuations, which can trigger the cardiac arrhythmias, and especially atrial fibrillation can be a challenge. There could be an altered response to various anesthetic medications, which probably Dr. Meenakshi Sundaram is going to address to. And also understand that there could be high chance of post-operative urinary retention when you advocate the spinal or epidural anesthesia in these patients. Cardiac complications, you all are aware, but remember that diabetic patients are most vulnerable to develop heart failure during the emergency surgical procedure or in acute stress. And the commonest heart failure which is found out in these patients is usually heart failure with preserved ejection fraction, which is very difficult to pick up and extremely catastrophic sometimes. So always be watchful. Ask your cardiologist to look at specifically the diastolic dysfunction, and also look at the E by E prime ratio on the echo. Now, if E by E prime ratio on echo is more than 8, that tells you that this patient is likely to develop heart failure with preserved ejection fraction, and you'll have to be ready with that. Also, look at and watch for the cardiac arrhythmias. Keep a close watch on the urinary output as well as the electrolytes, not only during preoperative sessions, intraoperatively, but even during the post-operative phenomena. Okay, understand that whenever possible, the best therapeutic intervention is using an intravenous insulin infusion. Shilpa asked me very specifically to talk about, what are the drugs that should be stopped and what are the guidelines for the adjustments of the OHs. And here I'll do it briefly in next 2 or 3 minutes. Alpha glucosidase inhibitors, usually names are generally acarbose or voglibose. can be taken as regular as on the day prior to admission, but if the surgery is posted in the morning, you can omit the morning dose. Now, preferably, my recommendation is this, that all the diabetic surgeries should be planned in the morning times. But if at all there are emergencies, then the situation is different. Meglitinides also we do not use. The commonest used meglitinide is ripaglinide. That can be continued as normal on the day prior to the admission, but omit morning dose if the patient is nil orally. Metformin, preferably before major surgery, stop a day prior or 48 hours prior. Because in a dehydrating situation, metformin can sometimes trigger down the lactic acidosis. So be very watchful, but surely omit on the day of surgery. Sulfonylureas can be taken as normal on the day prior, but especially the long-acting sulfonylureas, I generally recommend to stop at least 48 hours before. Now, what are the long-acting sulfonylureas that we use? Are glibenclamide, that is downhill, or we can also consider gliclazide as probably a moderate acting sulfonylurea, can be stopped 48 hours. Glimepiride or glipizide can be continued as normal on the day prior, but on the morning of the surgery, omit it. Pioglitazone can be continued as before during the admission, first day of admission, but stop during the day of surgery. SGLT2 inhibitors, there is still a little difference of opinion between the endocrinologist, diabetologist, nephrologist, and the physicians. But what is generally recommended is this, that SGLT is to be off before the major surgery. You can stop it at least a day or two and assure that the patient is adequately hydrated, because sometimes SGLTs can trigger the ketosis. Now, the new drugs which are currently the sensations are GLP-1 receptor agonists, and the commonest are liraglutide and semaglutide. They can be taken as normal, but always be watchful that the patients, especially those who have got gastric neuropathy or a gastric autonomic neuropathy, you should be very, very watchful, because GLP-1 receptor agonists can cause delayed in the gastric emptying. It can cause delay in the gastric emptying and cause excessive PONV. So be very watchful while you are, probably managing these patients. Generally, as a rule, what I practice in my clinical practice is that I prefer to avoid all the non-insulin anti-hyperglycemic agents on the previous day if I get a chance, especially for the major surgeries. Now, coming quickly to the diabetes and surgery, what are RSSDI guidelines clinical recommendations? If the patient is on basal only therapy, that means the patient is taking only once in a day a long-acting insulin, patient can continue to take the same dose if the dose is generally given at the night time before the surgery. But if the patient is on with the twice in a day dose, or if you feel that the patient was very well controlled before coming to the surgery, then it is always advisable to reduce the dose by around 10 to 25% depending on the clinical scenario or case-to-case base. Twice in a day dose requiring insulins, especially insulin like insulin detemir or levimir, generally it is recommended that you can give that insulin in the morning times, but with a little reduced dose of around 25%. Right, Dr. Meenakshi Sundaram will be talking about this in more details to you all guys. Basal and prandial insulins need to be adjusted case-wise. Preferably, stop any prandial insulins, or what we also call them as nutritional insulins, like regular insulin, Lispro, Aspart, Glulicid, can be stopped if the patient is nil orally, but continue with the basal injection. Always remember that do not miss the basal shot. Talking about premixed insulins, friends, premixed insulins need to be continued, but generally reduction by around 20 to 50% of the dose depending on the previous medications as well as the diabetes control. Understand that if there is a renal compromise, please do not resume metformin in these patients with renal dysfunction. It is necessary. In the limited care settings where you do not have the access to the investigations like electrolytes or dipsticks or maybe probably creatinine or urea, see to it that the patient is hemodynamically and metabolically stable. In the limited care settings, if the surgery is emergency, the patient is decompensated, it is always advisable to refer the patients to the higher centers if possible. Always design a plan to actually manage these patients properly in the limited care settings. Last 5 minutes, I will be talking to you about how would you manage these patients on the insulin. Must remember that blood glucose above 80, you should always trigger insulin infusion and try to keep the blood sugars between 140 and 180. The glucose levels less than 110 and more than 180 are not recommended. Now, there are two different ways of managing. Some practice what we call it as the variable regimen. There is something called as a fixed regimen also. Do not practice sliding scale. But what I recommend is that all of us should follow a protocol. Irrespective of whatever protocols that are existent in your institution or in the hospital, follow the protocols. And there are so many of them. There are Portland, Yale, Markowitz, Medanta, Mayo, or even RSSDI. I follow RSSDI Endocrine Society protocol. What protocol you follow, it is not important. What is important is that its presence in your institution and everybody sticks to it. Generally, insulin infusions are the best way of administering insulin during the intraoperative period. Always remember that there have to be two different lines or two different cannulas for the insulin administration and the administration of the other drugs. Do not mix them up. Prepare the insulin pump according to what you're seeing on the screens. Generally 50 units in 50 ml of normal saline in a 50 ml disposable syringe. And usually do not forget to flush around 15 to 20 ml to charge or to saturate all the insulin binding sites in the tubings. Now, how would you start? Always give priming dose of around 0.1 unit per kg if the blood glucose is more than 300, and the bolus has to be always a prandial or a nutritional insulin. So it can be either a regular human actrapid or any one of the analog insulin, rapid acting analog insulins that you have. Now, once you have done that, how would you calculate the maintenance dose or an infusion rate? Simple formula, blood glucose divided by 100. So for example, if blood glucose is 200, just simply divide by 100. And you know that you are going to initiate this patient on 2 units per hour. Now we have started well, right? Monitor every hourly by either a capillary blood glucose, or you have a venous line, or if you have an arterial line, probably monitor the blood glucose every 1 hourly. Probably if the surgery is going to be prolonged, at least once every 4 hourly, manage and find out about the potassium. Keep on checking regularly about the status of the insulin pump. Remember this golden line, friends, that 1 unit of insulin neutralizes 3 grams of in vitro, that means outside the bottle, and 40 milligrams of glucose in vivo. So whenever you are starting the infusion, always find out what is the current status, what were the previous capillary blood glucose levels, what is the current rate of insulin infusion, and find out how the blood glucose is changing. For example, if the blood glucose goes up after 30 minutes or an hour's time of we have started the infusion, increase the infusion. That is fine. That is very well understood. But if blood glucose fall rate is less than 30 milligrams, still you need to increase the infusion dose. So if the rate of the fall is less than 30 milligrams, increase the infusion dose. And if blood glucose is falling more than 30 milligrams, then probably you can continue till the time blood glucose reaches 180, and then probably you can adjust accordingly. So this is generally a rough example of the situation where we are starting at 200, but if suddenly in a patient, the blood glucose goes to more than 240 after 1 hour, increase the rate by generally 3 units per hour. If it is between 211 to 240, increase by 2 units. 180 to 210, still increase by 1 unit. But in a patient who is responding, the fall is there, but it is not adequate. That means more insulin requiring patient or more insulin resistant patient. These patients will still call for the increase in the insulin infusion. The last part or the bottom part of the table is very important. If the blood glucose starts coming down below 110, if the patients, those who are requiring more insulin, that means they are more insulin resistant, and shown that despite of inducing the insulin, the blood glucose has gone up. Keep them watching and do not stop insulin. In the rest of the two areas, you need to hold insulin the moment the blood glucose starts coming down below 110. If the blood glucose ever dips down below 70, always hold insulin and give 25% dextrose. If the patient develops hypoglycemia, follow this rule that check the blood glucose every 30 minutes, restart the infusion at the 50% rate after you have corrected it till the time the blood glucose reaches more than 140 milligrams, and then slowly you can resume the original infusion rate. If the patient has developed a severe hypoglycemia, monitor more frequently and reduce down the insulin infusion till the time the blood glucose reaches 50% and continue with the 50% of infusion after the patient has crossed 140 milligrams. This is roughly how do you practice the variable insulin regimen. I will not go into the details, but we are using the same principle that 1 unit reduces down or neutralizes 3 grams of glucose inside the bottle or 40 milligrams of the sugar in the blood. So if you are starting with the 5% dextrose infusion, naturally 5% dextrose will have 25 grams of glucose. So you'll add 8 units of the either a regular insulin or a regular insulin analog, and accordingly adjust depending on what you are seeing on the table. Always watch for hypoglycemia. But if the patient develops hypoglycemia, then what will you do? Always remember that there is a hypoglycemia protocol. If blood glucose is less than 70, it's not that 100 ml of 25% dextrose you will inject. No, that will induce more glycemic variations. So what is the formula to calculate how much 25% dextrose to give? 100 minus blood glucose and multiply it by 0.8, that is a correction factor. And blood glucose, if for example is 40, give around 48 ml of 25% dextrose and keep on repeating blood glucose every 15 minutes till the blood glucose crosses more than 70. Till it crosses more than 70, continue the same protocol. The moment the blood glucose crosses more than 70, start checking every 30 minutes. Then if the blood glucose crosses more than 90, check 1 hourly. And once blood glucose levels reach more than 140, restart the infusion at the 50% of the previous levels. So these are the pearls of the intraoperative management, friends. Hourly monitoring, keep blood glucose levels between 90 to 180, preferably 110 to 180. Monitor potassium at least 2 to 3 hourly. Keep potassium between 3.5 to 4.5. If you are giving larger doses of insulin, always supplement the insulin infusion with potassium, either 20 to 40 milliequivalents depending on the previous potassium levels. Always understand that usual intraoperative monitoring should be considered and suspect hypoglycemia if at all there are any challenges. So to conclude, friends, as I have tried to, probably rapidly, talk to you about how do you manage the preoperative and intraoperative phase. Perioperative, I will not dwell into because of the want of the time, but it is always challenge to manage diabetic patients, those who require anesthesia. It is always preferable to have an acceptable metabolic control before you actually initiate. But then if it is an emergency surgery like this, then probably let us come to our first question, that should we wait till the time the sugar is more? Now this patient is having a carbuncle, he or she can wait, probably start with the good antibiotics, be watchful, and the moment you get a first chance, probably, you have started managing him or her on with, insulin, get down the sugar below 200 and then take the patients in the operation theater. Right? If the patient is decompensated, if the patient is metabolically unstable, patient has the signs of septicemia with peripheral vascular collapse, then probably with the high risk consent, we can still take the patients. If the patient is conscious, are there any guidelines? Yes, we did discuss them, right? Now, if the patient is if this patient can be in ketoacidosis, ketosis, yes, but acidosis, especially in type 2 diabetic patients, is very unusual. Generally, do not start soda bicarb till the time the pH is less than 7.2. Till the time the pH is 7.2 and above, you don't have to initiate soda bicarb, and never ever give boluses of soda bicarb. Whenever you are trying to treat acidosis, Soda bicarb has to be slowly corrected with a 100 ml per hour infusion. Infusion needs to be given. Do not initiate these patients with the boluses. Can we give anesthesia with the mild to moderate ketosis? Yes, because there are a lot of other drugs which can also cause ketones. So don't worry, ketones are not the challenge. Acidosis is the challenge. You should monitor electrolytes, preferably in the longer periods of surgery. Keep a watch on sodium and potassium, both, preferably potassium. Urine ketones do not matter, so forget about them. They are the poorest tool of management, so do not use them. If you have got a facility to find out about the serum ketone levels, there is nothing like it. Urine ketones can be sometimes deceptive. As far as the electrolytes are not feasible, probably ask for the help, and especially in the decompensated patients. The changes which are expected are usually hypo or hyperkalemias, generally hypokalemia, which can trigger arrhythmias. Especially be watchful for the development of atrial fibrillation and acute heart failure. Bicarbs, we have already discussed what to do. So to conclude, friends, I love these lines by our late President Abdul Kalam, and of course the champion guy, that the greatest reason for the failure is not ignorance. It is the illusion of knowledge. So be watchful in all of your patients. Thank you very much for your kind attention. I know that I have exceeded my time by around 10 minutes, but I really will appreciate your feedbacks, your comments, and I would be happy to answer any questions. And I'll beg your pardon and permission to leave because my OPD is waiting.
Sir, thank you for your excellent presentation. Not only the content, but the slide also very lucrative. And many of my doubts about the insulin perioperative management were very clear. But I think the same feeling about the many of our members. But there are few questions in the chat box. Actually, this session is open for the question answer. So anybody can ask directly, or I will read some of the questions.
Yeah, if you can.
How much time is taken for the result of HbA1c report is the question.
How much?
Sir, 1 minute. Sorry to intervene.
Yeah.
Dr. Meenakshi Sundaram. Dr. Meenakshi Sundaram.
Yeah.
Please, if the subsequent lecture is also followed, I think it can create intricate questions because he has covered it very nicely as an opening batsman. So I think before going into the question and answer session, let my session is also over so that the doubts will be.
So there are going to be so many other questions as well. So be
it
ready
will
for
open.
all these difficult questions from this.
It will open new discussions. It
Yes.
will open new discussions.
Oh, yeah.
So I think it is better.
Yeah, okay. Fair enough.
Okay.
Whatever you feel, all right. So take that. That is absolutely your no issue.
Supriya madam.
Pramod sir, you have some question in your chats, so we can go quickly through that and then we'll move to another session.
Should we take a few questions?
Yeah.
Yeah.
Fine.
It is better to have the second.
How much time is taken for the results of A1C? 30 minutes.
Yeah.
And nowadays the point of care A1Cs are also available. So it is easier to do even, with the point of care. So generally within 30 minutes, the A1C reports are available. Shilpa has asked if there is an autonomic neuropathy.
Autonomic neuropathy, yeah.
How would you diagnose? Yes, of course, depends on what kind of an organ that is involved. Generally, we are watchful for the postural hypotension in these patients. We are watchful about the unusual bradyarrhythmias in these patients. The patients, those who complain of excessive bloating and all, these are the patients, those who are asked for the history of the, gustatory sweating in them, or warm shake hands, or warm feet, or, wet shake hands and wet feet. Stinky socks can be an indicator for the autonomic neuropathy. The shoes stink, the socks stink, the shake hand is wet. The patient gives you gustatory sweating. Gustatory sweating is not just a sweating after probably, having a spicy food. Gustatory sweating is while even you are eating the normal regular lunch or dinner. If the patient complains of that, these are the patients in whom you should be watchful. So that is the way you generally find out, especially gastric autonomic neuropathy, excessive flatulence, bloating, not feeling hungry for a long time. These are the symptoms that generally patients, they will come to you.
Okay.
If Shilpa again asks if the metformin and sulfonylurea, if not stopped after 48 hours before, what would be the complications? You will have to be watchful for the both challenges, especially if the patient is on with the long-acting sulfonylureas like glibenclamide, you need to be careful while initiating the insulin infusion and being watchful for the hypoglycemia proactively. So probably the monitoring will go up better. And nowadays, what we generally recommend to most of the patients is that there is a new monitoring device which has come. I don't know how many of you are aware about it, but that monitoring device is called as a flash glucose monitoring by the name of Libre. Now, there are two different devices which are called as Libre and Libre Pro. Libre Pro is more, I would say, for the general practitioner or the doctor use, but Libre is for the personal use. So that patient can put on the sensor, or you can put on the sensor to the patient, and you have got a reader. So you have to just scan the reader above the sensor, and it will not only give you the reading, but also will show you the graph arrow-wise, what are the likely readings. So if the graph is going vertically up, that means the blood sugar is likely to shoot up. If the graph stays diagonally slightly up, then the sugars are likely to be up. The graph is diagonally down, that the patients are likely to experience the lower sugars. And if diagonally or the vertically down, you should be understanding that the patient is surely going to develop hypoglycemia in next half an hour's time or so. So there are different ways of monitoring. So here in this situation, probably you need to increase the monitoring. But generally, I always prefer that sulfonylurea as metformin should be stopped at least a day prior. It is always better, so that we are more than sure about how the patients are going to be. And I always have that feeling that little sugars on the little higher side, up to around 180, are more acceptable than too tightly controlled sugars. And I will be extremely watchful in those patients who had a very tight blood glucose control, A1C less than 6 on 2 or 3 or 4 OHs. You should be watchful in them. Be very, very careful in them.
Okay.
How much is the difference between the sugar levels done by the glucometer and the lab? There is a difference, but nowadays the new glucometers are available, which are fairly well calibrated. So you don't have to be really worried about that. The technology has changed significantly. But remember that there can be a difference between the lab and the glucose levels, depending on what glucose you do, whether you do a arterial glucose or a venous glucose. And also, if you're doing a sugar by the capillary blood method, then you have to understand that the difference can be anywhere between 15 milligrams to 15%, depending on the sugars. 15 milligrams, that means if the sugars are too tightly controlled, really sugars are in between, say, 110 to 180, the difference can be 15 milligrams. But if the sugars are 300, then the difference can be 15%. So be very, very careful and watchful in that times. Okay.
Sir, there is one more question is there.
Yeah.
After what age should it be mandatory to check the blood sugar level when patient don't give any history of diabetes or ratio?
What age?
After what age it is compulsory to do the blood sugar level?
Most of the times, all the patients. What is the challenge? You do not know the patient. Simple blood glucose estimation is advisable for everyone who is getting hospitalized for the anesthesia requiring procedure.
Okay.
In fact, I'll tell you that friends, follow the same guidelines that are followed in the intensive care unit while you are managing patients in the operation theater. Operation theater is far more challenging than the intensive care units, and who better than you guys know this? So it is important for all of you to understand that the same protocols have to be followed as far as the management and the controls of diabetes are concerned while you're managing patients in the medical ICCUs or during the intraoperative period in the operation theaters.
Okay.
So last question I wanted to ask you.
Yes, Balaji.
Sir, it's really a wonderful presentation. Means content, text, slides, everything is superb, sir. So I really appreciate it.
Thank you very
Sir,
much.
the
Balaji.
question is, you told that there should be a baseline insulin should be given, and on the top of that, you should manage with the short-acting insulin.
Correct.
But during surgery, particularly kidney transplant, CABG surgery, invariably, rather than giving baseline insulin, we tend to manage only with the insulin infusion.
Yeah, now that is the place where we commonly commit error, Balaji.
Okay.
Now, always remember that you try and do it yourself in your hospital and you'll realize what I'm saying is true. Have a set of the patients who do not receive any basal insulin and manage them on just the prandial insulin in the hospital patients, in the wards, and find out how their glucose status or sugar status is. And use a basal shot and then adjust the prandial insulins. So the basic golden rule of management of any diabetic patient is fix the fasting first. And how do you fix the fasting? is by giving a basal shot, because that takes care of that basal glucose metabolism. This is what exactly the pancreas does. Every 7 minutes, 1 unit is secreted in the circulation. Pancreas only secretes one type of insulin, isn't it? Pancreas doesn't secrete different types of insulins, right? Pancreas secretes only one type of insulin, but it secretes continuously at the
Yes.
base. Now, that is what we call it as the basal insulin secretion coming out from the beta cells. Now, you need to take care of that. And on the top of it, when you manage, not only you achieve a better glycemic control, but the requirement of the prandial shots also goes down significantly.
Thank you very much, sir. It's a really wonderful talk.
Thank you very much.
Thank you, sir. Very
So,
crisp and clear
Can I
lecture.
leave, please?
All our
I'll
doubts.
rejoin if it is possible, but I will
Yes.
request you to permit me because I'll need to
Yes.
start my OPD again.
Yes,
Okay.
sir.
Thank you, sir.
Sure. Thank you very much. Good night, everybody, and thanks for the wonderful opportunity. Dr. Sundaram, over to you. I am sorry that I have exceeded your time. I know you are sitting in Srinagar. We understand that, but we have also appreciate that you joined this session. Thank you very much. Bye-bye. Good night.
Thank you, sir.
Yeah.
Now we'll move towards our next session by another stalwart, Dr. Meenakshi Sundaram, sir. We really appreciate his enthusiasm and love for sharing his knowledge with all of us. Actually, he is in Kashmir at present. So we are going to play his audio lectures, but he will be available for question answer session. I request Dr. Sujata, our GC member, to introduce Dr. Meenakshi Sundaram, sir. Sujata?
Yes. Good evening, everyone. Thank you, Dr. Pramod sir, for conducting the webinar till now very flawless. And thank you, Dr. Tivaskar sir, for briefing us and giving us the brief insight about the such a complicated topic. Now, as we have sent our patient to the physician and physician has given fitness, now it's our turn to give anesthesia. And to talk on diabetes and anesthesia implication, today we are having another great orator with us with a high glycemic index of oration, Dr. Meenakshi Sundaram sir. We all have witnessed sir in various conferences. Wherever sir start, the hall is totally full, the house full, and many of the delegates even they stand outside and to listen to sir's talk. Sir is a multi-talented, multifaceted, and an accomplished faculty, always in touch with Maharashtra, and the only faculty out of Maharashtra having an MMC accreditation. I take the privilege to introduce Meenakshi Sundaram sir. Sir is a former director of medical education, Tamil Nadu. Sir was dean and DME for 10 years in government service. On ISA National, Sir was an ISA National Vice President in 2016. Being an anesthesiologist, Sir has an upper hand in as administrator, as a teacher, as a poet, and so many areas of interest. To his credentials, Sir has many awards to his account. And to name some of the prestigious awards are Best Doctor Award by Government of Tamil Nadu. And I guess this is the only award given by government of any of the state to a doctor or an anesthesiologist. Best Teacher Award, Best Tamil Nadu Scholar Award, and 12 more awards to his credit. Wow, that's really endless. It's a sweet gesture to introduce such a tall personality on our today's platform. And I really welcome Dr. Meenakshi Sundaram sir on AAA platform to talk on diabetes mellitus and anesthesia implication. His highest commendable commitment we can witness today as he's on vacation. Still, he sent us an audio, which we will be playing shortly. And sir will be available for question and answers. Mr. Ganesh, can we have sir's audio? I welcome Dr. Meenakshi Sundaram sir. Yeah, we can start the audio. Mr. Ganesh?
Yes, ma'am.
It's not.
Sujata, should I?
Ah. Yeah. No, just now we saw the same PPT. Ganesh is there? Yeah, please.
Outset, I thank the Society of Association of Aurangabad, the Anesthesiologist Society of Aurangabad chapter. I am fond of Maharashtra and always I feel away from home whenever I am talking to delegates in Maharashtra. And today, because of our uncontrolled friendship, the Aurangabad Society have given me a topic, uncontrolled diabetes mellitus and anesthesia management. So I thank once again the State Society of Anesthesiologists of Maharashtra and Aurangabad Society. So when it is going to be the uncontrolled diabetes mellitus, problem is much more severe because diabetes mellitus itself is a very big chapter. And understanding diabetes mellitus is very, very difficult. For example, understanding a man is very easy, but see, part one, how to understand a woman is like this. This is applicable for diabetes also. So the diabetes and anesthesia within 45 to 60 minutes, even though it is difficult, it is fairly a good timing, 45 minutes. So I will try to finish it within 45 minutes. Now I am having a good duration to cover the entire area. And the type 1 diabetes mellitus is insulin dependent. We used to say it is insulin dependent because there is absolute deficiency in insulin, whereas the insulin sensitivity is normal. As the type 1 diabetes mellitus occurs in young individuals, the complications occur in adulthood, and the complications will be the premature vascular disease and myocardial infarction, whereas the type 2 diabetes mellitus, you can even see the fast food culture has produced the diabetes mellitus 2, that is NIDDM, non-insulin dependent diabetes mellitus. Whereas if you are a vegetarian and if you take a lot of vegetables, you will be fairly maintaining a normal glycemic control. So because of the older and overweight, the type 2 diabetes mellitus occurs. So what happens to the metabolic response during anesthesia and surgery? In any anesthesia and surgery, there is increase in cortisol and catecholamine secretion. There is increased sympathetic activity and increased growth hormone and glucagon secretion. Because of this, what happens? There is reduced insulin sensitivity. At the same time, there is reduced insulin secretion. So the sugar control goes up. So because of this metabolic response to anesthesia and surgery, gluconeogenesis, glycogenolysis, proteolysis, lipolysis, everything occurs that may lead to a complication of diabetic ketoacidosis or hyperosmolar non-ketotic coma. So out of all the diabetics who are at increased risk, type 1 diabetes mellitus patients are at increased risk. Patients who are overweight, having excessive abdominal fat, and patients, in addition to diabetes, if they are on steroids and polycystic ovarian disease, they are at increased risk. If I say increased risk, you may ask me, what risk? So the risk will be in any diabetic mellitus patients. You please think of these risk factors. One is a renal compromise. So the renal compromise, because the diabetes affects kidney, so you have to check that. Diabetes affects brain, so that may manifest as a stroke, a peripheral neuropathy, autonomic dysfunction, retinopathy, or reduced joint mobility. And more than that, it affects the heart also. So a diabetes, always when there is a case of diabetes, think of cardiovascular complications. So the delayed gastric emptying
affects the stomach. So all diabetic patients are considered as full stomach patients. And because of all these things, there is a multi-organ dysfunction. Everywhere there is a rupture. Everywhere there is a problem. So that is a problem with the diabetes mellitus. So what other risks, specifically in cardiovascular area, diabetes mellitus is equal to coronary artery disease. So there is an increased risk for myocardial infarction. And if the patient is suffering from a previous myocardial infarction, then the risk factor is more. So the presence of autonomic neuropathy and erectile dysfunction are strong predictors of silent myocardial infarction. And the longer duration of diabetes mellitus, there is increased chance of ischemic heart disease. So the heart failure is more common in diabetes mellitus patients, and a poor glycemic control leads to both systolic and diastolic dysfunction. In addition to the cardiovascular risk, as I said, the renal compromise is severe in diabetes mellitus. And the chronic kidney disease may be asymptomatic for a longer period and suddenly it may manifest. And when you analyze the patients who are undergoing dialysis, almost 50% of the patients will be diabetic. And it produces preoperative renal failure, can produce postoperative renal failure also, and postoperative infection. In addition to that renal compromise, the diabetes mellitus produces stiff joint syndrome and reduced neck mobility that is manifest as prayer sign. When the patient mimics a prayer, the little fingers will not approximate. So that a prayer sign indicates there is a stiff joint syndrome which may interfere with the endotracheal intubation. So the anti-diabetic agents are so many, which Dr. Mangesh Tivaskar explained. So I need not go into the details of anti-diabetic agents. So this is for completion's sake, I am saying the mechanism of action of the drugs. And this I want to concentrate. See, you may be wondering why so many heroines have come up. Why they have come, just to say there are so many varieties of insulin. So all insulins will be attractive. Dr. Mangesh Tivaskar has clearly explained the availability of insulin. So insulin available in wide range, like many heroines in the cine field. And everyone will be picking up one, not the heroine, one insulin. Every diabetic patient, according to the whims and fancies of the treating physician, they will pick up one insulin. They will be knowing only that insulin. But when the patient is coming for surgery, we have to know all the heroines, all the insulin, so that we can titrate the dose in the perioperative period. So we have variety of insulins, which Glulizin, Lispro, Aspart, Detamir, Glargine. But what I want to convey, as an anesthesiologist, we should know when the insulin starts acting and what is the peak activity and how long it will act. And in the perioperative control, mostly the anesthetist will be dealing with rapid acting insulin, short acting insulin. So we have to be very thorough with it. All the other insulins, we should know the pharmacology and the dosage just to titrate, or the morning dose, 50% of the dose. So to calculate insulin dosage, we have to know everything, but routinely anesthesiologists will be using the rapid acting insulin. So this is acting curve for completion's sake. So when you want to use insulin judiciously, think of mixed, so that it will be a short acting and a intermediate acting combination. So in surgery and general anesthesia, that is my part to say how to manage anesthesiology in diabetes mellitus. The surgery and general anesthesia are relatively insulin hyposecretion, which I have already explained. Because of the increase in stress activity, there is a reduced insulin secretion and the insulin resistance is reduced. And the release of hormones like growth hormone, glucocorticoids, they also reduce the insulin sensitivity, which causes acute hyperglycemia. So that hyperglycemia causes dehydration, impaired wound healing, and increased rate of infection. And it worsens the central nervous system injury with the ischemia, hyperviscosity, and thrombogenesis. In a nutshell, the surgery and anesthesia are catabolic. That is, we are doing catabolic activity during surgery, but in diabetes mellitus, we want anabolic effects. That is the problem. When it produces catabolism, we want anabolism. So why we want to do that? The glucose, high levels of glucose, they produce toxicity like non-enzymatic glycosylation, and it leads to formation of abnormal proteins. They reduce the elasticity of the joints that produces stiff joint syndrome. Same way, they affects the endothelium also, and increased macroglobulin production increases viscosity that promotes intracellular swelling as well as the thromboembolic phenomena. So, in a short, glycemia disrupts auto-regulation that we have to maintain. This auto is incidental, not coincidental. In addition, in diabetic patients, we'll have microalbuminuria. So the microalbuminuria, if the HbA is HbCA1 actually, sorry for the typing mistake, HbA1c, if it is more than 8.1, there is a chance of microalbuminuria, and 30 to 300 milligram albumin per 24 hours is microalbuminuria. But up to 29, there is 80% chance of renal insufficiency. So we have to screen the microalbuminuria so that the drugs excreted through renal route can be titrated. So the different degrees of hyperglycemia require to damage different vascular bed. So at one level, retinal vessels will be damaged. At another level, cerebral vessels will be damaged. At another level, cardiac vessels will be damaged. So we have to analyze that. This, most of the anesthesiologists are forgetting. If the patient is suffering from diabetes mellitus, there is accelerated physiological aging. So the accelerated physiological aging means, even though our age is maybe 30, we have to treat them as 52.5 years in type 1 diabetes mellitus if it is not controlled. Same way, the type 2 patients, they will be imagined to have 1.5 times the age. So that is how the organ damage occurs. So in addition, the diabetic patients are suffering from autonomic neuropathy. So if the patient is suffering from autonomic neuropathy, the intraoperative hypotension chances and perioperative cardiorespiratory rate arrest are increased, and there is an exaggerated pressure response to tracheal intubation. In addition, the autonomic neuropathy predisposes to intraoperative hypothermia. Worse still, if the patient is suffering from hypoglycemia and if he is suffering from autonomic neuropathy, he will be unaware of that. This is just like a silent myocardial infarction. Still, the list is not ending with autonomic neuropathy. Atropine action, it will be questionable. Beta block of action, it is questionable. This is the funniest part of autonomic neuropathy. It can itself produce tachycardia, it itself can produce bradycardia. So we cannot predict. So in elderly, long-standing diabetes mellitus patients, we have to be very careful and we have to scan them for autonomic neuropathy. As I said, the autonomic dysfunction may involve the denervation of vagal control. Same way, it can denervate the cardiac accelerator control also. So it can produce tachycardia, it can produce bradycardia. And because of autonomic neuropathy, the respiratory reflexes are altered and impaired ventilatory responses to hypoxia and hypercapnia. So when you will suspect autonomic neuropathy, early satiety, then the lack of sweating. Even in summer, they will not sweat. And the lack of pulse rate changes routinely. That is how we clinically examine the patient. The pulse rate changes with inspiration or orthostatic maneuvers. Same way, the erectile dysfunction indicates autonomic neuropathy. In addition, postural hypotension and a resting tachycardia gives a clue that the patient may be suffering from autonomic neuropathy. Same way, nocturnal diarrhea and peripheral neuropathy also indicates autonomic neuropathy. We have to check. And in diabetic patients, sometimes they suffer a sudden cardiac arrest or sudden respiratory arrest. So this interference with the respiration or sinus automaticity may be by coexisting pneumonia or because of our anesthetic drugs, sedation, pain medication. The difference between maximum and minimum heart rate change during inspiration is 5 per minute in diabetic patients. If it is so, then we have to think the patient is having a chance for sudden cardiac arrest. And when we want to decide the dose of insulin, in diabetic patients, the minor surgery and the major surgery, we have to change the nomenclature. So if the food intake is allowed within 24 hours, it can be considered as a minor surgery because glycemic control is easy. But if the patient cannot receive food intake within 24 hours, then it should be considered as major surgery because you have to give glucose at the same time you have to give insulin. If there is a hyperglycemia, what are the clinical facts, warning signs? Infection rate is 2.7 times higher if the blood sugar is more. If you want to practice hypotensive anesthesia, it is preferable to have a blood sugar less than 200. If it is more than that, we have to be very careful about ketosis. And in perioperative period, if you practice tight control regimen, then chances of hypoglycemia will be more and the mortality is increased in uncontrolled diabetes mellitus. That is our topic. So with this background, if you come for anesthetic management, I will not say which anesthesia will be preferable in diabetes mellitus. It has to be decided case to case basis and it depends on the expertise of the anesthesiologist. So the anesthetic management, the catch point will be blood glucose level only is not important. I want to stress that blood glucose level only is not important. It is also important, but it only is not important. The important point is we have to assess the end organ damage. Because in the theater as well as in ICU, the end organ assessment is important. If the patient may have a very high blood sugar, but organs may be working pretty well, that is easy. So the target by World Health Organization during perioperative period, they mentioned 108 to 180 by so many researchers. But practically what I want to convey, the 72 to 216, it is preferable. We can manage. Less than 70, there is a pretty good chances of developing hypoglycemia. And as I said, if you want to practice hypertensive anesthesia, the blood sugar should be less than 200. So instead of 108 to 180, you can actively manage if the sugar is within the range of 70 to 210. But if it is increased, there is a chance of perioperative and post-operative infection. So in the anesthesia management, glucose control is not same for all the cases. The glucose control is influenced by the type of operation, whether the patient is pregnant or not, and what are all the CNS insult like autonomic neuropathy the patient is having. And it depends upon the bias of the primary care physician as well as the anesthesiologist and the type of diabetes. So when to switch over to active insulin control, if the patient is taking oral hypoglycemic agent, when to switch over to active insulin control, all type 1 diabetics, they should have insulin. And the people who are suffering from NIDDM, if they are not controlled by oral hypoglycemic agents, they should switch over to insulin. Same way, the HbA1c, if it is more than 9, and the fasting blood sugar is more than 190, then they have to switch over to insulin. But I stress, it should be decided on case-to-case basis. So with this in mind, when you evaluate the patient preoperatively, first assess the end organ damage and the glycemic control. Then while we are eliciting history and doing physical examination, we have to focus on all the systems, mainly the cardiovascular, the renal, gastric and neurologic system, because these are all the areas affected mostly in diabetes mellitus. So to give a clue regarding asymptomatic coronary artery disease, you have to ask for early satiety, erectile dysfunction, numbness in extremities, postprandial vomiting. And in the preoperative chart, always document all peripheral pulses and document skin breakdown, because of the peripheral vascular disease, some pulses may not be palpable. And during the perioperative period, if suppose the right radial is not palpable during the perioperative period, if you check the right radial and you may be wondering what happened to the pulse, suddenly you will get stuck. So always mention what are all the pulses felt, what are all the pulses not felt, and skin breakdown. This documenting skin breakdown and the documenting sensory examination is vital, especially if you are practicing a regional anesthesia. Because if the patient is suffering from peripheral neuropathy, and if you are giving spinal anesthesia for the patient, and if the patient is having a sensory loss in the postoperative period also because of diabetes mellitus, then you will be blamed that the spinal anesthesia has created this sensory disturbance. Same thing applicable to skin breakdown also. So these are all the vital points. So always document pulse, document skin breakdown, and document the sensory nervous system, and document orthostatic vital signs, because they give a clue about autonomic neuropathy. So patients with autonomic dysfunction have more than 20 millimeter decrease in systolic BP, or 10 millimeter difference in diastolic BP when changing from supine to standing position. That has to be recorded, because autonomic dysfunction, as I already enumerated, it can throw light on many subjects. Then we have to do ECG. ECG, as you know, it is to document coronary artery disease or arrhythmia, and blood urea creatinine electrolyte glucose estimation is to document the renal parameters, and multiple glucose levels and HbA1c to assess the control of glycemia. Then diabetic patients will be taking so many medications. Minimum 10 I have seen the patients are taking 2 oral hypoglycemic agent, then with aspirin, then some ACE inhibitors, beta blockers, so many drugs they will take, multivitamins, neurotropic vitamins, many things they will have. So you assess the concurrent medications and their effect on anesthesiology, and again assess the end organ damage and autonomic neuropathy. The autonomic neuropathy, as I suggested, the diabetic patient should be treated as if they are suffering from full stomach, because the gastroparesis is very common. Silent ischemia and cardiac arrest is also common. And with this, when you want to pre-medicate the patient, I am giving only the points. So you can use ranitidine, metoclopramide, beta blockers and atorvastatin is accepted. Aspirin and ACE inhibitors, you have to think and decide what is the dose of aspirin, whether it could be continued or not. If it is a minimal, it is accepted. But if it is more than 300 milligram, you have to be very careful. Same way, the ACE inhibitors produce precipitous fall in blood pressure, mainly if you go for a central neuroaxis blockade, and never venture with anticholinergics, because the rate disturbance will be a problem in analyzing autonomic neuropathy, or it will increase the increase in rate will increase myocardial oxygen demand, so it can produce myocardial infarction. So the investigations: HB, ECG, X-ray chest, urinalysis, total count, creatinine, electrolyte. You need not do echocardiography for all the cases. If you suspect, if you have any doubt, then you go for echocardiographic evaluation. So in the goals of perioperative management, it's very easy to say, you avoid hypoglycemia, you avoid hyperglycemia. Both the things. That means it is a tight glycemic control. But the tight glycemic control itself is a controversial point. So very, very salient point. In diabetes mellitus during anesthesia, you have to avoid hypo and hyperglycemia. But the tight control is controversial. And arterial and capillary glucose, they value approximately 7% higher than the venous blood. Now I will give you anesthetic agents influencing glycemic response. See, the etomidate is a wonderful drug because it diminishes cortisol secretion. So it diminishes hyperglycemic response. So etomidate is preferable. Etomine increases the blood glucose level. Same way, the benzodiazepines and opiates, because of their sedative effect, they reduce the sympathetic activity. So they reduce the hyperglycemic episodes. But if the benzodiazepines and the opiates doses are increased, they may lead to impaired ventilatory reflexes. So we have to be really careful. Same way, the halothane and isoflurane, they inhibit insulin secretion. The dose-dependent decrease in insulin secretion. So when you are using halothane and isoflurane, you have to be very careful. Same way, the central neurax is blocked, epidural or spinal. It is wonderful because it blocks the sympathetic fibers and it reduces the stress response. But if the patient is suffering from autonomic neuropathy, then the patient can develop dangerous hypertension in epidural and spinal anesthesia. In spinal anesthesia, it will be more precipitous than epidural because epidural, the sensory, sympathetic, motor blockade will be at the same level, whereas in spinal anesthesia, the sensory blockade will be 2 segments above and the sympathetic blockade will be further 2 segments above. So the precipitous fall in BP will be there with the spinal anesthesia. We have to be very careful. Another point, if you are giving epidural or spinal and the surgery is over within an hour, the patient has to wait for 1 more hour for a recovery. So rapid recovery from anesthesia is preferable because it will unmask the symptoms of hypo or hyperglycemia. Neuromuscular blockers, they don't have a direct action on the glycemic level, but while selecting the neuromuscular blocker, you have to think the route of excretion and whether that organ is working well or not, you have to document and use. So as far as insulin is concerned, there are so many modifications. So as a guideline, you discontinue all short-acting insulins on the day of surgery, and it can be allowed only if it is given by a continuous pump. For type 2 diabetes mellitus, half of the dose for long-acting and combined insulin on the day of surgery. Whereas if it is insulin-dependent diabetes mellitus, 1/3 of the usual morning dose. So only basal rate is allowed for the insulin pump. These are all the things just to begin with. Then you have to control in the perioperative period. So in the control, in the perioperative period, there may be no insulin, no glucose regimen, or tight control regimen, or non-tight control regimen. So in the no insulin, no glucose regimen, the pre-existing glycemic control, if it is good, and for a minor surgery, we can practice no insulin, no glucose regimen, where breakfast and oral agents are omitted. No glucose, no oral hypoglycemic agents. So they should be omitted. And if it's a long-acting sulfonylurea, it should be omitted a day before surgery. And avoid dextrose infusions. Blood glucose should be checked every 2 hours. And start drugs as soon as possible. That is when the patient regains oral intake. Then comes the non-tight control regimen for a postgraduate should be short notes. So the non-tight control regimen means it's a loose control. See, sometimes being loose are also preferable, especially for this. Because in a non-tight control regimen, the aim will be to prevent hypoglycemia. So to prevent ketoacidosis and hyperosmolar states. So roughly you have to maintain at 130 milligram glucose approximately. How to maintain that? maintain nil oral after midnight. At 6 a.m. on the day of surgery, 5% dextrose to be started, 125 ml per hour per 70 kg body weight. And after starting intravenous infusion, give off the usual morning insulin dose, preferably subcutaneously. Then in the perioperative period also, same thing to be continued. 125 ml, that is, one bottle will flow for 4 hours roughly. One bottle should be flow for 4 hours for a 70 kg individual. In the recovery room, monitor blood glucose concentration and treat on a sliding scale. Sliding scale means it is very easy. Depending upon the sugar, you have to give insulin. But it is not much useful in poorly controlled diabetes mellitus. And it cannot continue for days together. And the sliding scale, you can very easily remember, start from 150, increase 50, 50, 50, 150, 200, 200 to 250, 250 to 300, 300 to 350, above 350. Right side, you write 2, 4, 6, 8, 10. So it is very easy to remember. Now, this gives a clue. See, the frequent testing only will help in the control of diabetes mellitus. So we need not have expertise or extra intelligence. However great you may be, you have to check the sugar, then only you can use insulin. So this is how we can manage no sugar, no insulin technique. So in the tight control, previously what you have described is a non-tight control, where this insulin is given on a sliding scale. So the tight control, it is for pregnant diabetics mainly, because it will help the child also. The same way for diabetic patients undergoing cardiopulmonary bypass, tight control is needed. Same way people who are having the vulnerability to develop stroke, we have to use that. So in a non-tight control, it is 130 milligram per deciliter. But in a tight control, it should be kept between 80 to 120, that is between the normal value. It improves wound healing and it improves the neurologic outcome. It improves meaning from cardiopulmonary bypass. So in the tight control, on the evening before surgery, check blood glucose level. Then you have to add insulin via a picky bag. So you start infusion 5% dextrose in water instead of 125 ml in non-tight control. You are giving now 50 ml only, and 50 ml saline with 50 units insulin, 1 unit per ml. It should be a piggy bag. Then you have to check blood sugar 4th hourly and glucose divided by 150 or 100. That is the required dose. So in the perioperative period, you have to monitor glucose. Then if the blood glucose is 150, then it has to be divided by 150. So 1 unit insulin is required per hour. If the patient is suffering from some disease and taking steroids, then they require more dose. So if the patient is taking steroids, it has to be divided by 100. So if the blood sugar is 150, the patient is not taking steroid, the dose is 1. If the patient is taking steroids, the dose will be 1.5 units. So intraoperatively, every hour you have to check the blood glucose. This is the key bag infusion. And the routine thing is the Alberti regimen, GIK regimen, glucose, insulin, potassium regimen. So this is to avoid hypokalemia, insulin-induced hypokalemia. So 15 units of soluble insulin with the 10 millimoles of potassium chloride is added and the mixture is given over 5 hours. So if the patient is able to take orally, you have to go for subcutaneous insulin. This potassium is added because insulin moves the potassium intracellularly. So even though sometimes the total body potassium is normal, serum potassium will be low. So it has to take care of that. So in the supplemental regimen, usually it will be done by the short-acting insulin. So we have to check the blood glucose and divide the insulin requirement. If it is afternoon list, give a reduced dose of insulin before early breakfast. whatever I say, the theme is very clear. Hyperglycemia is preferable than hypoglycemia. That's what I stress. If at all the patient has to develop hypoglycemia or hyperglycemia, better the patient develops hyperglycemia, because the hypoglycemic insult, if it is produced in the central nervous system, it is not reversible, whereas hyperglycemia can be easily treated by insulin and the insult could be reversible. So give reduced dose of insulin, and the patient should arrive at the facility by 9 a.m. and blood glucose should be monitored in the preoperative ward. And you can give only regional anesthesia and general anesthesia. General anesthesia, already I said, etomidate reduces, and halothane, it increases the sugar level, and opiates and benzodiazepines, they reduce the hyperglycemic response. So if you go for regional anesthesia, the local anesthetic requirements are lower and the risk of nerve injury is higher in diabetic patients. It is applicable for nerve block or central nerve axis block. Then combining local anesthetics with the epinephrine is there is a greater risk for ischemic injury. And hemodynamics is in associated ischemic heart disease, you have to be very careful. Same way autonomic neuropathy, because central nerve axis block produces drastic hypotension. In emergency, rule out diabetic ketoacidosis. But even if the patient is suffering from diabetic ketoacidosis, if the underlying pathology leading to diabetic ketoacidosis, then you have to treat the patient simultaneously for diabetic ketoacidosis. At the same time, you have to administer anesthesia also. So preferably any surgery could be delayed by 4 to 6 hours. So if it is so, you can attempt to correct the diabetic ketoacidosis and you can take up the patient. If you cannot wait for even 4 hours, then you have to go simultaneously, you have to proceed. So how do you have to proceed in those situations? 0.1 unit per kilogram, that should be given as a bolus dose insulin, and 0.1 unit per kg per hour is the initial prescription. Then serum glucose should be monitored hourly, and electrolytes are monitored every 2 hours, because that is also important, because potassium, magnesium and phosphates, they will be reduced and they have to be replenished only after documenting the urine production. That is, urine secretion is to be there, then only you can supplement these electrolytes. So when you are using non-dextrose fluids in diabetic ketoacidosis, if the blood sugar reaches 250 milligram, then you have to add dextrose and you have to give insulin. Insulin has to be continued till the acidosis resolves, not the blood sugar level is reaching normal value. Insulin to be continued till the acidosis is resolved. So in an emergency surgery, just wait for a few hours, as I said. If it is not so, you have to proceed with the treatment as well as the anesthesia. So treat the volume deficit, that is important, because in a diabetic ketoacidosis, there is a gross volume deficit, and if you give spinal anesthesia, the BP drop will be very severe. Then you have to tackle the volume deficit to tackle the arrhythmias and hypotension. So insulin in ketoacidosis, 10 units regular insulin as a bolus or 0.1 unit per kg. As I said, the glucose is divided by 150 would be the basal infusion per hour. If the patient is taking steroids, divided by 100. Again, frequent monitoring is important than the insulin dose. Now I want to give a clue. During fluid resuscitation, glucose falls rapidly. First, in the initial 1 to 2 hours, glucose falls very drastically. That is, if the glucose is 400, it will come to 300 very easily. But insulin binding sites are limited. So the drop in glucose level may be 75 to 100 milligram per hour. So you need not give insulin 50 units, insulin 100 units, not possible. You have to wait and it has to gradually come down. If you drastically reduce glucose level, it will produce cerebral edema. So the IV fluid Routinely in diabetic ketoacidosis, minimum 3 to 5 liters required. Sometimes it can go up to 10 liters. Here, more water loss than solute. But even then, the sodium level may be reduced. And when the sodium level is reduced, you have to think of pseudo-hyponatremia. Because of hyperglycemia and hypertriglyceridemia, pseudo-hyponatremia can occur. So here in this picture, only one man is there. All are a non-living object, but he is a real man. All these are pseudo. So you have to think of pseudo-hyponatremia before attempting correction of sodium. Sodium decreases 1.6 milliequivalent per liter for every 100 milligram increase in glucose. So the 250 to 1000 ml of NS normal saline, you need not go for 3% saline because it produces spontaneous myelinolysis. And 1/3 correction is attempted in the first 8 hours, and the 2/3 correction is to be in the next 24 hours. And in the diabetic ketoacidosis, the routine analysis of ABG is mandatory, preferable, easy to treat. So if you see, there will be acidosis with increased anion gap. Same way, ketones, lactic acid, and increased organic acids will be there. In this diabetic ketoacidosis, never venture with soda bicarb. Soda bicarb will produce more harmful effects. So insulin itself will correct this acidosis. If you give sodium bicarbonate, it will produce paradoxical acidosis of CSF. That is, sodium bicarbonate will not cross the blood-brain barrier. So the CSF will be acidic. It will stimulate the respiratory center, but the periphery will be alkaline. So the respiratory alkalosis produces more alkalosis. Again, as I said, hyperglycemia can be easily treated than hypoglycemia. So acidosis can be easily treated, but alkalosis is very difficult to treat because that ammonium chloride is the antidote, which is not available. So that is very difficult. So never venture with the sodium bicarbonate in diabetic ketoacidosis. So if the pH is less than 7, that is a neutral pH, then only you can give soda bicarb, that too only 1/3 of the calculated dose. So till the pH is becoming 7, you need not venture with sodium bicarbonate. Why the 7? 7 is the neutral pH, and below 7, myocardial depression occurs. So you can venture, and if you are venturing with sodium bicarbonate, you have to think the sodium bicarbonate increases the intravascular fluid balance also. So you have to think that. And in the ketone bodies, first beta hydroxybutyrate subsides, then acetoacetate, and acetone comes. So acetone will be always positive. Till the acetone becomes negative, you have to continue insulin. So if there is a persistent ketosis with bicarbonate less than 20, if blood glucose is normal, it means you have to give glucose and insulin. Because of the lipolysis, ketosis will be there. So as I said, even if the blood sugar is normal, if there is a ketosis, you have to give glucose and insulin. So in the electrolyte disturbance, you have to treat hypokalemia because insulin shifts the potassium intracellularly, and the potassium is excreted in the urine because of increased delivery of sodium to the distal tubule. In addition to potassium, phosphorus deficiency also occurs. But before replacing phosphorus, magnesium, potassium, ensure urine output. And in the post-operative period, as I said, the net effects of neuroendocrine responses on metabolism is increased blood glucose, stimulation of lipolysis, and increased rate of gluconeogenesis. So everything contributes to ketosis. So in the post-operative period also, blood glucose level monitoring should be continued. So in a high dependency unit, the patients has to be monitored and continue infusions till oral intake, and keep 150 milligram blood glucose and change to preoperative schedule after oral intake. So the total insulin requirement will be 50% long acting at bedtime, and the remaining 50% in short acting 2 to 3 divided doses. pain relief is vital because increase in pain, that will increase glycemic response. So for completion's sake, now I want to say there are so many advances in diabetic management, and the anesthesiologist should know. These are all the pocket equipments. So I want to add that. So there is a smart vein finder. You can take it everywhere, and just you can see for venous cannulation, you can use this smart vein finder. And now smartphone glucometer is available. Now every pocket equipment is connected with our smartphone. So you can use that and you can monitor it in our smartphone. So glucose monitoring system is working wirelessly with our smartphone. So tight control is easy. And now this is just like a walking encyclopedia, this is a walking pocket equipment. The glucose monitoring is through pain-free, non-invasive continuous monitoring. Now most of the doctors are wearing this because it is costly. I think per month it will work out to 20,000 rupees. So this is a small disposable patch. So in the upper arm it is fixed, and you can monitor with the smart watch or your smartphone. It will actually, whenever you require, you can measure the blood glucose level, because there is an electronic sensor, and the trade name is Sugar Beat. This patch takes sensor measurement every 5 minutes. So whenever you need, just to switch it on, your blood glucose level will be seen. Digital plaster is also available. See, the digital plaster, it is just like a NIBP monitor. It measures blood pressure and the temperature and the glucose levels. It is just like a plaster. It contains a silicon chip. It is powered by a small battery. Again, you can monitor everything to smartphone or central computer database. Even further, the anticipated newer treatment will be, time is not far. Implanted glucose analyzer can come. At that time, tight control will be very easy because the glucose analyzer is implanted. It will give signals. Same way, the new islet transplantation. So the islet neogenesis associated protein, that is INCAP, which may cause regrowth of normal pancreatic tissue. So if there is a regrowth of pancreatic tissue, type 1 diabetes mellitus disappears. Even with so many advancements, I want to inform all of you, accept things you can't change. If you can't change in diabetes mellitus anything, you accept and modify your plan. So if the tree could not be cut, a house can be constructed with the inclusion of the tree. Same way, always be prepared for plan B. Be prepared for plan B in diabetes mellitus. Mainly in autonomic neuropathy, anything can happen. Why these people have come? Just I want to say, irrespective of position, friends would be always in touch. So the Maharashtra is in constant touch with me. That is friendship. I enjoy the company with the Maharashtrians. So I thank once again the ISA Aurangabad, and I thank ISA Maharashtra also.
Ganesh, you can stop sharing. Meenakshi sir, are you there?
Yeah, I'm available.
Thank you very much for this wonderful presentation, and your slides were as beautiful and as pretty as the brands of insulin, I must say, and as smart enough with all the smart gadgets which you showed us for the glycemic control. Thank you very much, sir. Can we have Balaji sir for the word of wisdom?
Yes, it was really a wonderful presentation with lot of humor in it. And it is always pleasure to listen Dr. Meenakshi Sundaram, sir. Thank you very much, sir, for presenting on our platform.
And I must say, sir is very much techno-savvy as well, because
Yes.
sir has presented this in picture quality with a good audio and good clarity of presentation. Thank you. Thanks a lot. You have taken a lot of effort for this, sir. I appreciate your efforts. A few things which I gathered from your presentation, I just want to quickly highlight those things. The one is we must look for the risk of diabetes in various organ damage. The most neglected part, I think, is the stiff joint syndrome, and patient may come up with difficult intubation. Then the microalbumins and the autoregulation, which you specifically highlighted, exaggerated autonomic nervous response. There may be exaggerated pressure response during tracheal intubation. Atropine and beta blockers, the action may be unpredictable. And the vagal, denervated vagal tone or cardiac acceleration control, impaired response to hypoxia and hypercapnia. Yes, as you rightly mentioned, that blood glucose level is not important, but end organ damage is very, very important. And documentation of peripheral pulse and skin breakdown is important. Hyperglycemia is preferred and can be controlled rather than the hypoglycemic insult. Also, avoid soda bicarb, as both of the faculties have highlighted on this point, to avoid soda bicarb in diabetic ketoacidosis. And the last time, but not the least, accept the things which we cannot change. Thank you very much, sir. We can take few of the questions from the chat box, sir, if you're comfortable.
Yes, yes.
There was a question that thromboprophylaxis is required in diabetes mellitus for long surgery.
It is not compulsory, madam, but we have to be very careful. The patient can go in for thromboembolic episodes, but thromboprophylaxis only as far as diabetes is concerned, it is not compulsory. But if coexisting diseases are elderly, even I have done an international double-blind randomized control study comparing elderly at the end stage illness, medical illness, whether thromboprophylaxis helps or not. So it is only the individual choice. It is not compulsory as far as only diabetes is concerned.
That's great, sir. Whether the BSL of more than 230 and patient is posted for lap hysterectomy, what should be our plan? Should we wait or should we proceed?
Yeah, we can, madam. We can, because again I stress only diabetes, only blood glucose. We need not postpone the case. We need not postpone the case. So it is only the combined decision.
Yeah, comorbidities, obesity, the cardiac risk.
If suppose the patient is hostile, or if you think the patient may create a problem, then you say you till wait till the sugar reaches 200. But that doesn't make much of a difference between 200 to 230.
How much time the ketone takes to decline, and shall we wait till the ketones to become negative in an emergency procedure?
Madam, in emergency, first decide whether 4 hours can be allowed or not. That is the anesthesiologist decision. Even if minimum 2 hours is allowed, can be allowed, then you proceed with the correction of ketosis. If suppose not even a single minute is to be wasted, then you immediately intubate and proceed. But at the time of IPPV, if it is a general anesthesia, I want to stress, in acidosis, the patient may be hyperventilating in acidosis, but just to balance that, what we call it as a Kussmaul's respiration. But we are not supposed to hyperventilate because we are not supposed to produce alkalosis as that it produces paradoxical acidosis. So in the IPPV period, we have to be very careful because we think once it is intubated, we will be ventilating just like that. So ventilate is a normal pattern, 12 to 15.
Okay. That's great, sir. Neuropathy in the lower limb, spinal anesthesia can be given in that case?
Yeah, that is again and again we stress documentation of sensory problems in the lower limbs and the skin breakdown, because the patient may blame spinal anesthesia. We need not do any mapping for that. You document and get a consent from the patient that having a disturbed sensation. So the spinal anesthesia may not be a reason for disturbed sensation in the lower limbs in the post-op period.
Sir, connecting question with this only, if there is a diabetic foot or a debridement posted for debridement, we mostly give this ankle block, even though that is a peripheral neuropathy. So should we proceed if the skin changes or skin inflammation is there, or we should not give any, or we should avoid the ankle block in such patients?
Madam, what you are asking is, if the skin color has changed, ischemic insult has happened, whether we can go for ankle block. Ankle block. But when there is a ischemic insult, when you are giving these local anesthetic agents, the requirement will be very low in that. but we can go a higher level of blockade, because even at the level of ankle, it may not be sufficient. So you can go up at the knee level with ultrasound guided blocks. Everything is very
Yeah.
easy. So it is
Easy.
only a subjective decision.
Yes, sir. And which category of diabetes mellitus patient is 2D echo essential, sir?
As I mentioned, see, it is not routinely required, madam. It is not even ASA, I mean, Indian Association of Anesthesiologists, ISA, even they have declared it is not mandatory. But if you want to screen the patient with a 2D echo, ensure whether you think the patient may develop silent myocardial infarction, or is there is a chance of cardiomyopathy the patient can develop. In that case, you go for 2D echo, or else it is not needed.
That's great, sir. Depending upon the surgery as well, we can suggest if it is a
Yes,
spine
that
surgery, going
now
to the
we are,
prone.
now we are talking only about diabetes mellitus, madam.
Diabetes. Yeah.
Not
This
about
is
the surgery. That is the reason I say, see, if suppose we are concentrating everything about diabetes mellitus, then a robo can do. That is the reason we are there. Because if suppose associated hypertension is there, associated, how we can diagnose? That is the reason I say, see, we have to be very conscious. Even while ventilating, we have to be conscious. Because that acidosis, we are not supposed to neutralize it. Physiologically, it should get neutralized. So these are the things everyone knows. At that particular point of time, your mind should work.
work.
So coexisting
Dr.
diseases and all.
Yeah, Dr. Varsha Agrawal, ma'am, you raised the hand. Please go ahead. You want to ask something? Dr. Varsha Agrawal? Okay, we'll proceed with further question. Uncontrolled diabetes since 20 to 25 years, then what specific risk factor we should explain to the patient or to the relatives?
Specific is main. First is cardiovascular. First is cardiovascular. Again and again.
Yeah.
Because that produces a rapid insult. Then subsequently renal and cerebral. With autonomic neuropathy, peripheral neuropathy. These should be in sequence.
Oh. So in case of hyperglycemia causing hyponatremia, small doses of furosemide should be given?
No. See, it should be only the glycemic control which will correct that hyponatremia. Because the hyponatremia only at the level of 125 it produces symptoms. Routinely that will not happen in that. So once the correction of acidosis corrects all the electrolyte abnormality in a diabetic. So we need not specifically go for that.
That's it, sir. Sir, and in case if the TLC count is more than 15,000, contraindication for, is this a contraindication for spinal?
Which is more than 15, madam? I could not get your
Total
question.
leukocyte count is more than 15,000. Can we go ahead with spinal?
What is the correlation? Infection.
Probably,
if you suspect it, madam,
infection.
that is the wild imagination. That is a infection. That when I was doing my post graduation, they used to say infection. That infection can produce pyogenic meningitis. That and all wildest imagination, madam. We can proceed because we are going to give antibiotic in the para-operative period as well as in the post-operative period. There's no relevance.
Yeah, that's great, sir. I think Shilpa madam has also posted one more question regarding fluid in diabetes for longer surgery. Shilpa madam, are you there? What you want to ask regarding fluid?
Yeah, I'm very much there.
Yeah, ma'am, you can proceed. You asked something about IV fluid in long-standing, prolonged procedures, right?
Like a patient with head and neck surgery and has diabetes. So what fluids? It's ring lactate, normal saline, or what? Like, how many normal saline, how many ring lactate?
Madam, it is preferable in long duration surgeries. 2 lines are better. As we planned previously, we can plan whether it is going to be a non-tight control. I am the strong advocate of non-tight control. I am not interested in tight control as it produces so many problems. So a dextrose insulin line should be separate. Non-dextrose fluids should be separate on the other line. So it is not the matter of fluid. It is the glucose insulin fluid should continue as a separate line, either as a piggyback or a 2 separate line. 2 separate line is preferable. 2 separate line is preferable. So one line is only glucose and insulin. So check blood sugar every 2 hours. And as far as this
Avoid
normal saline,
catabolism. The glucose insulin drip to avoid the catabolism.
which one?
The glucose insulin drip to avoid catabolism.
Yeah, to some extent we can control because we want anabolic effects. As insulin is anabolic hormone, we have to do that. So again, if you want to go, you can plan whether it is 125 ml per 75 kg man or 50 ml. But it is preferable, it should be a separate infusion, and we can calculate the dose of insulin and dextrose routinely. We used to give a syringe infusion. But if you want to give more fluid, dextrose fluid is not at all needed. So non-dextrose fluids can be used in long-standing surgeries. And this 50 ml syringe, 50 ml diluent and 50 ml insulin can be kept. So that is 1 international units per ml. So that the correction will be easy.
Sir, and regarding 2D echo, you said not required, but sometimes we have young diabetics now, 40, 45-year-old, coming for medium surgeries, like say thyroid surgery. So in those cases, is it like they might have autonomic neuropathy and they may undergo? So do we need to have 2D echo preoperatively?
Madam, as I said, if you suspect myocardial infarction, silent myocardial infarction, if I say, it indicates autonomic neuropathy. It indicates autonomic neuropathy. So then only there is a chance of myocardial infarction is increased. Then if you suspect dilated cardiomyopathy, that is common in diabetics. But just because a patient is labeled as diabetes, we need not do all the tests as a routine. That is what I want to say. I want to stress also because the youngsters should not be afraid. Once that sugar is more, everything will happen. We have to be very careful with that.
For the young diabetics, not even
We
for
need
young
not do,
diabetics.
madam. We need not do a echocardiography as a preoperative investigation as a routine.
Okay, sir. Thank you so much. Thank you, Sujata madam.
Thank you, ma'am.
Thank you. Thank you. So recently, post-COVID, after intake of Remdesivir, we are looking more forward, means more of the patients are coming younger age with this diabetes. So they are really very tricky to manage. And as you have given a brief insight about and whether to go with general or regional anesthesia and the things we should be very careful about. So that was a very excellent presentation and excellent talk and insight given by you, sir. Thank you very much.
Meenakshi
I
sir,
think, Supriya madam,
Meenakshi
we
sir.
are,
Hello.
yes.
Yes, Dr. Varsha.
Yeah, this is Dr. Varsha. Just one small question, Meenakshi sir.
Yes,
Tell me,
please.
madam.
Yeah, I'm from Pondicherry, sir. Remember me?
Yeah, I know.
Sir, one small question. For ophthalmic cases,
No,
what should be
you
the
can
blood
ask,
sugar cutoff?
madam, you can ask a long question, madam. No problem.
No, sir. No, routinely because I'm going to Arvindai, the cutoff is always like troubling us, sir. What should be the cutoff, fasting and postprandial?
It is, see, madam, again, I stress, it is that too, for a cataract surgery, nothing is
Yeah.
required. For cataract surgery, see, they are actually they are overestimating that this will not heal, that will go off. It will
Yeah.
not. Madam, then overnight, if you control blood glucose level, nothing you
Yeah.
are going to change. It should be a gradual control, steady control. So the patient would have been taking long-term medications. He would have controlled to some extent. So there
Yeah.
is no hard and fast rule that the blood sugar to be this much, that much. So if patient or the surgeon wants to know what is the ideal blood sugar, random blood sugar he can have, I will suggest 220, madam. 220,
Yeah,
up to
220.
220, patient can have sugar level, glycemic level. We can safely anesthetize 220.
And postprandial 200 is okay, sir. That is what we are
Yeah, madam,
taking
when
the
I said
patients.
200, when I say 220, 200 is okay.
Okay, no? That is what, sir.
Definitely nothing will happen.
And fasting up to 140 we are taking, sir. That's
Madam,
okay, isn't it?
That's what I am saying. Random 220 means if it is fasting postprandial, madam, that too, as I said, your cataract is going to be a minor surgery because the patient is going to take food immediately. Another one, nowadays they are even giving topical anesthesia and they
it's
are
with
operating.
topical only.
See, again, madam, I stress, let me tell one point.
Yeah.
The preoperative assessment,
Yeah.
I used to tell all my postgraduates, the preoperative assessment is not to go by lab values. We have to think of the flow phenomena which occurs on the third day. The third day only, because initially the shock condition will be there. So ebb phenomena will be there. flow phenomena will occur on the third day. So if any surgery is going to activate that hypermetabolism on the third day, it creates some significance and we have to modify that in the preoperative period. Now,
Correct.
cataract is not going to produce any hemodynamic change. Why we
That
should
is
be
true,
worried
sir.
about that? Routinely is
Yeah.
going to take his tablet, even if he need not go for insulin also. See, overnight
Okay.
starvation, first case, he is going to take food and he can go. So in
Yeah.
no way, this cataract surgery, mainly because people are asking cataract only. Now, even in the Supreme Court, the cataract fees limitation case has come up. So for diabetes and cataract, nothing will happen.
Okay, sir. Thank you, sir. Thank you so
Thank you.
much. Yeah.
As we are ranging from 100 to 200, sir's talk and discussion with sir is going
Yes.
on 300 percentile. So let's move ahead.
We
We
can,
have
ma'am.
one more faculty with us. Yes, sir.
So, we will love,
Yes.
we would be love to interact with sir, but we have a time concern. So thank you so much, sir. Your lecture is as usual awesome and full of tricks and tricks. And we really appreciate your commitment to stick your word that even you are on vacation, you are available for us. Thank you so much, sir.
Thank you, ma'am.
Yeah.
Thank
Now
you.
we'll move to our next session. That is that will be a really seesaw ride. That is thyroid ups and downs. By Dr. Amla Kudakar, madam. I must say she is a great teacher that I had experienced during my residency, and I have learned so many practical tips and tricks as well as the theoretical knowledge from her. And now today is again I got that opportunity to listen from her. I request Dr. Sanhita Kulkarni, madam, our AAA executive member, to introduce Dr. Amla, madam.
Good evening, all. Till now, we had a very informative talks by our stalwarts, also practically useful discussions by Dr. Tivaskar sir and Dr. Meenakshi Sundaram sir. And now we are coming to our next talk by another stalwart in anesthesia, Dr. Amla madam. I am very privileged to introduce Dr. Amla madam. She is, of course, a very well-known academician and great teacher, currently working as professor and head in the Department of Anesthesia, St. George's Medical College, Mumbai. There are numerous achievements on madam's name. Only few of them I am going to mention. Needless to say, she has a many publications on her name. She is a co-editor of the book, namely Practical Approach to Anesthesia for Emergency Surgical Procedures, which is very helpful in day-to-day practice. Also, she has written chapters in the book, namely Anesthesia and Trauma. She has not only started pain clinic, but also started separate pain OT in Sion Hospital. She is a NMC and DNB appraiser. She has taken initiative in starting 14-bedded anesthesia intensive care unit in St. GS Medical College, Mumbai. It's a very great achievement. She is a member of prestigious District Quality Assurance Program, which monitors quality of health in reproductive and child health. Now coming towards our today's topic, that is thyroid ups and downs. We are now coming across very frequently patients with thyroid disorders, and that are creating very much dilemmas. Which patients are to be accepted, which are subclinical, which patients lie in the subclinical group, and which patients need antithyroid or thyroxine supplementation. Now over to you, madam, to clear our doubts and highlight on this topic. I invite Amla madam to proceed for the lecture.
Shall I share my screen?
Yes, madam. Yes.
Yes, madam. Yes, madam.
Is it seen now?
No, madam. No.
Madam, I think the camera is off from your side.
Actually, now it is on. That is what I was
Yes.
wondering. I cannot see myself, you know.
No, it's showing the symbol of camera and an oblique sign. So that means your probably the video or camera might be off.
Basically, um, I am not seeing myself on the anywhere on the screen. So I don't know by which name I have joined. Am I made a co-host?
Ganesh?
Yes,
madam. Yes, madam.
you are audible. That means you are a co-host, ma'am.
Yeah. But the video means whenever I click on that, it is Dr. Sachin Natsane's video, which is coming as, that's why I cannot have that.
You have joined from her mail link. That's why it's showing Sachin Natsan.
Yeah, but then
Ganesh, can you please help?
Yes, madam. Madam, please click on share screen.
एक minute. Yeah, share screen. Yeah.
Then तुम्हाला जी स्क्रीन शेअर करायची ना त्या स्क्रीनला
हो
क्लिक
केलं केलं
आता खाली
मग शेअर करते
यस यस होते मॅडम होते
Oh,
यस
yes, madam. Now
Yes,
we
we can
see.
Yes,
yes,
we can
you can
see.
just make full screen, madam.
Yeah, is it okay?
Yes,
Yes,
perfect, ma'am.
slide show yes
Yeah, I am on slideshow, but probably you
You can
cannot see me, no? That is the only problem.
Yeah, probably your video. Yes, ma'am.
camera
Yes,
problem
ma'am.
madam.
Yeah, it's okay now.
We are seeing your screen now clearly.
Yeah.
Yeah.
So good evening, everyone. The SAM's office bearers and ISA Society Aurangabad. Thank you for inviting me here. And I come from GS Medical College and KEM Hospital, Mumbai. And I will be speaking on thyroid ups and downs and its anesthesia implications. Let's see what is the importance of this topic. Next to diabetes, it is the second most common endocrine disorder. And the prevalence of thyroid disease, any of these diseases, be it subclinical or overt hypo or hyperthyroidism, is almost 20% in the society. That means 1 in 5 patients will have some form of thyroid dysfunction, and you are likely to come across these patients, not only for thyroid surgery, but for non-thyroid surgery also. It is quite common in females than in males. Considering the widespread effect of thyroid hormones on almost each organ and system of the body, any dysfunction of the thyroid will cause the functional derangement of so many organs and systems. So let's see what happens. It's extremely important to just brush the control of thyroid hormones to know and analyze the thyroid function TFT reports when they are given to us. In general, here what happens is the higher centers, it is an axis like hypothalamo, pituitary, and thyroid axis. So the higher centers will stimulate the lower centers to release their hormones. So hypothalamus will stimulate the anterior pituitary to produce TSH. TSH in turn acts on the thyroid gland to produce T3 and T4. On the contrary, T3 and T4 circulating levels will have negative feedback on the higher centers. And this is the basis for the entire TFTs that we must know. Just in short, what are the different types of dysfunctions? Whenever there is hyperactivity, it is hyperthyroidism. Whenever there is less activity, reduced activity, it is hypothyroidism. When do we call it primary? When the problem lies with thyroid gland. And when the problem lies with the higher centers like pituitary or hypothalamus, it's called as secondary or tertiary hypo or hyperthyroidism. The points here we want to maintain is there are two different categories, subclinical disease and overt disease. In subclinical, see always T3 and T4 will be normal, and these patients are most likely to be asymptomatic. Whereas in overt disease, T3 and T4 and TSH both will be increased or decreased in opposite direction. So it is very, after seeing this, you will be able to know that it is the diagnosis is done mainly by the value of TSH, whether it is hyper or hypothyroidism. And finally, secondary hypothyroidism or hyperthyroidism, all TSH and T3 will be either raised or low. They do not move in opposite direction. Now, how do we know that the thyroid gland is up or down? One look and you will come to know. So hypothyroidism, and mind you, I am talking about the extremes of the cases. So these patients, they will be lethargic, they will have dull mentation, reduced appetite, weight gain, constipation, menorrhagia, cold intolerance, coarse, dry skin, large tongue, periorbital and pretibial edema, and they will have bradycardia and low voltage on ECG. This can happen at the extremes of spectrum, but mainly what happens is, one patient had come to us when I was in KEM. The patient was a bank officer. She was working as a clerk in bank. And what she told is, in front of her window, there is always a huge line, whereas she was just not able to cope up with the work that she was given. And that is what she said. So these are the subtle changes which occur in hypothyroidism. Hypothyroidism is a very treacherous disease and you have to suspect it to prove it. So that is more important. Let's see clinical features of hypothyroidism and how it affects anesthesia. There will be reduced heart rate and reduced contractility. So these patients will be bradycardic and they will have poor contractility so that the cardiac output decreases by 30 to 50%. They have impaired baroreceptor mechanism. So whenever because of say you give spinal anesthesia or there is hemorrhage, the patient will not be take care of the hypotension. There is down regulation of beta receptors. So even if you were to give, say catecholamines to combat this, you will not be able to increase the blood pressure. They will have peripheral vasoconstriction, which increases the systemic vascular resistance. Now imagine an LV, left ventricle, which is not contracting properly. It faces the sudden increase in the systemic vascular resistance. It is bound to fail. Therefore, in extreme cases, there is cardiomyopathy and these patients can really go in congestive heart failure. And in a very delayed course, it will be pericardial effusion, especially in hypothyroid coma. So how does it affect us? Always it is better whenever you are suspecting, whenever you know that the patient is hypothyroid, it is always better to get ECG and 2D echo done to know the level of contractility, that is ejection fraction, the diastolic dysfunction, and the pulmonary artery pressure. POCUS can be done for on-table judging the contractility. Now, POCUS is point of care USG. So just whatever we do in our ICU, you just pick up that probe and put on the heart and you will come to know the level of contractility and the IVC size to guide about the fluid administration. Hypothyroid patients are at increased risk of coronary artery events because of the increased level of cholesterol, prolonged half-life of multiple coagulation factors. See, in hypothyroid patient, the metabolism is reduced a lot. So all the factors will not get metabolized. They are anemic because of the RBC maturity requires thyroxine, which is not there, and also because of the menorrhagia. And coronary artery disease, however, this is in dormant state because the metabolism itself is reduced. So it will not be manifested and you will be fooled that the patient is asymptomatic and nothing will happen during surgery or anesthesia. But during when exposed to the stressful conditions, the patient can show signs of coronary artery event. Effect on airway is obese patients, they are usually obese with short neck and there is deposition of pad of fat at the back of neck. They will have enlarged tongue and swollen oral cavity. So MPC will always be higher. Vocal cords will be edematous. On top of it, there is impaired gut motility and ileus. So the chances of aspiration, regurgitation and aspiration are high. All this make the difficult airway, like difficult mask ventilation, intubation, along with that, physiologically difficult airway. There is respiratory muscle weakness. Pleural effusions may be present. There is predisposition to atelectasis and pneumonia, and obstructive sleep apnea will be there. There is reduced hypoxic and hypercapnic respiratory drive. So even if the patient becomes hypoxic or retains CO2, it will not stimulate the respiratory center to, initiate breath. Because of this poor respiratory efforts, there will be hypoventilation, airway obstruction, hypoxia, and hypercapnia. Other miscellaneous consequences of hypothyroidism are anemia, reduced metabolism of drugs. This we already discussed. These patients are very much prone to develop hypothermia, and this we have to take care of during intraoperative period, as the patient tend to lose heat. Therefore, always make positive efforts to keep the patient warm, mostly by forced air warming or by the warming blankets. Post-operative, another important point is usually the fever heralds the onset of infection, but in these patients it may go unnoticed because the patients will be hypothermic and they will not have fever. Hypoglycemia also may go undetected under GA. Therefore, careful monitoring every 1 hour, 2 hourly HGT can be done. And hyponatremia can occur because of impaired free water clearance. Now let's talk about a few of the issues. That is preoperative screening for thyroid function is necessary? Let's see these two cases. This is a 60-year-old female patient. She was posted for elective open cholecystectomy with a starting heart rate of 47 per minute, and BP was 140 by 80 millimeters of mercury. After a standard induction of anesthesia, then she, everything went on smoothly. The BP increased after giving atropine 58 per minute, I mean the pulse rate. At the end, the patient did not come out after giving even the reversing agent, and she had low body temperature and bradycardia. Now, her blood, suspecting hypothyroidism, her blood sample was sent for assessment, and she had to be re-intubated. Patient recovered well after 4 hours after giving 2 tablets of thyroxine empirically through rice tube. Now, this was without the report. When the report came back, TSH was found to be 111 micro international units per liter. So she was severe hypothyroid. Similar case, this patient after standard induction, patient actually arrested. The patient had pulseless electrical activity, and the cardiac arrest was secondary to severe myocardial depression due to routine dose of drugs used to induce general anesthesia. So what was common in both the patients? Both patients were not diagnosed to have hypothyroidism preoperatively. They did give sign of hypothyroidism, but the anesthesiologist failed to capture that. Both had collapsed after a standard anesthetic induction. Both had delayed recovery, and they responded to empirical administration of thyroxine. So when should we do TFTs? Is it a must in all patients? Blanket rule. Routine preoperative screening for thyroid function in all surgical patients is not recommended. Now, all these are ATA guidelines. They may be performed in presence of symptoms or clinical signs of thyroid disease. Serum TSH may be used as a screening test because, in presence of disease also, in case of subclinical disease, T3 and T4 are essentially normal. So TSH you should use as a screening test for detection of thyroid disease in a suspected patient. And for this, you will have to keep a very thorough history as well as examination. After that, if you suspect that this patient might be having hypo or hyperthyroidism, go ahead and do TSH. A known hypothyroid patient or one who is being treated for hypothyroidism, TFT should be done preoperatively to determine the adequacy of treatment and to ensure that thyroid therapy is optimized prior to surgery. And a patient with well compensated thyroid disease for at least last 3 to 6 months who has documented euthyroidism on stable doses of medication, additional testing is not mandated. So if everything is stable, you can accept TFT, which are done 6 months back. Having said this, what rule that we follow is we accept TFTs up to 1 to 2 months. After that, we ask for repeat. Invariably, in a teaching hospital, most of the times the patients are screened by junior anesthesiologist students, and sometimes they may miss very pertinent history or examination. So we feel safer that a screening TFT is done. This all of you know that whenever the test is done, always see what is the reference level for that lab, and accordingly you fit the patient into hypo or hyperthyroid. Sometimes it is necessary to ask for free T4 rather than total T4 because thyroid, as you know, thyroid hormones, they are circulating in the body bound to globulin, thyroid binding globulin, and it depends upon the level of TBG that the total T4 can increase or decrease. So, which are the factors which increase the level? Use of contraceptives and estrogens, pregnancy, hepatitis, neonatal state, acute intermittent porphyria. Here the levels will be increased unnecessarily. Whereas these are the factors where it will be reduced. So always rather than going for T4, total T4, go for free T4. Now let's see what are the rules for each variety of hypothyroidism. In subclinical hypothyroidism, we know that T3, T4 are normal, but TSH is increased. In this category, case should not be postponed. Now, till what level you should accept this TSH? TSH level up to 10 milliunits, milli international units per liter can be accepted, provided the T3 and T4 are normal. So, by very definition, subclinical T3, T4 has to be normal. So, up to 10 milli units, it is commonly seen that T3 and T4 will be normal. Because there were multiple studies were done and meta-analysis that there is no significant difference in the outcome in normal patients and those with subclinical hypothyroidism. And which factors they saw? No difference in the anesthesia duration, lowest temperature reached, blood pressure, need for vasopressor, time for extubation, electrolyte disturbance, etc. So it was same in the normal patient as well as those with subclinical hypothyroidism. But moderate hypothyroidism, there is little difference. In elective surgery, should be postponed till euthyroid state is reached. Now, in thyroid, this is the dictum that no elective surgery should be done in absence of euthyroid state. Initiate thyroid hormone replacement as soon as the diagnosis is made. And how much should you give? Young patients are started on full replacement dose. And what is that? That is 1.6 microgram per kg per day. So for a 50 kilo, it will be usually 75 micrograms per day. However, if the patient is older or if the patient has cardiac disease, then it is started at the level of 25 to 50 microgram per day. The dose is increased every 2 to 6 weeks till euthyroidism is achieved. And how we define euthyroidism? Target TSH should be 4 to 6 units per liter. And then the tests are done every 3 and then later every 6 months and then every year. However, if it is urgent surgery, suppose patient comes for emergency surgery, then in a moderately overt hypothyroidism, they need to undergo surgery without delay. We cannot give that much 6 months of time to them. In them, start treatment simultaneously as soon as the diagnosis is made. Minor perioperative complications are to be expected and explained to the patient and the relatives. And which are these complications? Like higher frequency of intra and postoperative ileus, hypotension, hyponatremia, CNS dysfunction. Sometimes the patient may require ventilatory assistance in the postoperative period. So tell that. But this risk you have to take as the patient surgery becomes emergency. And severe hypothyroidism. Now, mild, moderate, or severe. These are just arbitrary terms. I mean, there is nothing clear cut. No book gives you a total, demarcation that up to 10. Usually it is taken as less than 10 or TSH level will be mild. More than 20 to 30, it will be severe hypothyroidism. So this is, and moderate is in between. It is a little gray area. Elective surgery again, as per the dictum, it should be delayed. Urgent surgery, the treatment should begin as soon as the diagnosis is made. And here you give T4 loading dose. Initially the previous moderate disease we gave as a replacement dose of 1.6 microgram per kg. Here you give T4 loading dose of 200 to 300 micrograms, followed by 50 to 100 micrograms daily. Sometimes in very severe hypothyroidism, when the patient is in coma, one may have to start intravenous T3 and T4 simultaneously. The initial dose is 5 to 20 micrograms, followed by 2.5 to 10 micrograms every 8 days. Way back in 87, 88, I still remember there was one patient who was hypothyroid, and the patient was taken for a cardiac surgery, and the patient did not come out. It was very difficult winning him off the bypass. And that time, I remember both T3 and T4 intravenous preparations were put in the bypass fluid. At that time, I had no idea what was happening. It was long ago, but this a very distinct memory of it. So exactly the dose will depend upon the patient's age and coexisting cardiac disease. Usually they have associated adrenal insufficiency also. So even that needs to be addressed, and hydrocort and or dexamethasone they have to be given. Now, how do we know the adequacy of treatment? Whatever treatment that we are giving is adequate or no? So how do you define normalization of the thyroid hormone indices and absence or regression of the clinical signs and symptoms? Clinical signs and symptoms may be delayed. You have to normalization of hormones will be an objective evidence. So you must go for that. Hypothyroidism is slow developing and extremely insidious disease, and difficult to judge the adequacy of replacement therapy on purely clinical disease because of lack of sensitivity and specificity. I mean, if you increase the dose of thyroxine from 50 to 75, the resultant change in the clinical parameters is not evident that fast. So TSH is the most reliable marker of adequacy of replacement therapy. There is increased risk of morbidity if TSH is more than 10 milli international units per liter, and potential risk if it is more than 7. So as far as possible, keep within the range of 4.4 to 4 units per liter. Let's see anesthesia implications and management. So first, await euthyroid state. Morning dose of thyroxine should be given. Let's consider anything, laparoscopic cholecystectomy, etc., where the patient will be nil by mouth for at least that day. But are you worried? Not really. On the morning of surgery, you are giving thyroxine. And if you see, the half-life of thyroxine is almost 7 days. So patient can sustain without thyroxine for 1 or 2 days till the nil by mouth is broken. So cases are best done, you don't have to worry. As far as possible, cases are best done under regional anesthesia wherever feasible. If the surgery is amenable to be done under regional anesthesia, go ahead and do, as it avoids the associated polypharmacy with hypothyroidism. Patients receiving central neuraxial block. Now, if the patient is well controlled, usually no problem occurs. But if the, in a haste or because of the surgeon's persistence, if you happen to give in a less than optimum patient, then you may land up because in severe hypotension, because the patient will not be able to compensate for the peripheral vasodilatation. There is refractory hypotension, and careful selection of patients and fixation of spinal level is important. The lower limb surgeries can easily be done. Even cesarean section and all such surgery, what we give is we give combined spinal epidural. So small spinal anesthetic dose suffices, and then you can give epidural extension by either plain saline, or you can give top up of epidural anesthetic also. Since there is down regulation of beta receptors, now what happens if there is hypotension? What you should do? If you give the regular doses of your drugs, vasopressors, they may not act, they may not have the same effect, because of the down regulation of beta receptors. So you may have to give little higher dose. Careful monitoring of cardiovascular parameters is must, and if required, non-invasive and invasively. The common drug that we give for this is noradrenaline. Then anesthesia management. IV cannulation may be difficult because of the thick and coarse skin. Sometimes it is better to straight away go ahead with USG guided central line. That is more practical approach. Of course, in reasonably moderate level of surgery. Use of short-acting drugs with low potential for accumulation. Use of short-acting drugs. Now we have remifentanil, use desflurane, which does not get accumulated in the body. Then use of drugs that do not cause respiratory depression or airway obstruction. Now, many times we do use dexmedetomidine provided there is no bradycardia to start with. So, if in a well-controlled patient, you can go ahead with dexmedetomidine. Just see how much the heart rate drops. Then use of drugs that lead to clear-headed recovery, like propofol. Midazolam is usually avoided. For muscle relaxation, short and intermediate acting to facilitate intubation, either suxamethonium, atracurium, or cisatracurium. And maintenance of either desflurane or propofol. Managing the airway is very important in this patient because a thorough assessment of airway for any difficulty. And now that we have this new wonderful tool, focus for airway if needed. Keep the difficult airway cart ready. And if the patient has OSA, such patient usually will be put on CPAP or BiPAP pre-operatively only or at the time of intubation. Always give head elevated laryngoscopic position for intubation, and use any good video laryngoscope so that intubation is really easy. Alternate source of oxygenation has to be given throughout the process of intubation so that the patient does not desaturate at the time of during the process of intubation. Intraoperative monitoring has to be absolutely thorough. Pulse, then ECG for tachybradycardia, arrhythmias, ST changes. These are very common in thyroid patients who are not well controlled. And of course, NIBP, IBP, SPA. Now, there are certain mandatory monitoring which is anyway we give. The remaining monitoring will have to be depending upon the severity of surgery, invasiveness of surgery, and the control of patient. ETCO2 is must both for hypo and hypothyroidism, because it may point towards the change in metabolism. Temperature extremely important because of hypothermia in hypothyroid patient and hyperthermia in hyperthyroid patient. Neuromuscular monitoring, BIS, MAC, all these are important so as to guide the delivery of muscle relaxant and inhalational or IV anesthetics. By using this monitor, it is possible to fine-tune your anesthesia. It is not needed to give more anesthesia than what is required. And of course, glucose to prevent that unwarranted hypoglycemia. At the end, the patients are very sensitive to actions of sedatives, narcotics, and anesthetic drugs because they have poor metabolism of drugs, thereby potentiating that action. Therefore, titrated doses of all medications with continuous monitoring. There is reduced sensitivity of respiratory center to hypoxia and hypercarbia. So they are prone for hypoventilation. There is altered sensorium and coma is very common, especially poorly controlled hypothyroid patient. And it potentiates the action of both depolarizing and non-depolarizing muscle blocking agent, leading to non-sustainable respiratory efforts. They have sluggish protective reflexes like gag and cough. And therefore, these are the candidates which are very prone for delayed recovery and failure of extubation. Remember that second patient that we discussed, the patient had to be re-intubated after extubation. What happens when the patient with hypothyroidism also has coronary artery disease? Usually, we saw that these patients are very prone to develop coronary artery disease. But in hypothyroidism, since there is reduced metabolism and oxygen demand, coronary insufficiency is masked by reduced demand. So they are in dormant state. Thyroid hormone, once you start the thyroid hormone therapy, it can backfire on you as it starts to restore the metabolism and it increases the myocardial oxygen demand. Patient can develop unstable coronary syndrome. Untreated hypothyroidism can worsen the heart failure and hypotension. If cardiac surgery with CP bypass is required, then there is usually inability to wean off from the heart-lung machine. This we discussed. So what is the solution? If the patient has symptomatic hypothyroidism, thyroid hormones may be started even in presence of angina. You have to weigh the pros and cons, but start with very slow dose. Initial dose of 25 microgram per day increased by 25 micrograms every 2 to 6 weeks as per the response. So don't go on that full replacement mode. Patients with angina can have coronary artery revascularization first and then can be started on T4. Post revascularization, 50 to 70% of full replacement dose is given. Maintenance dose is prescribed 4 to 6 weeks later on. We already saw that the drugs can be given orally in these patients. Now, how do we treat hypothyroidism in a patient who is nil per oral? Suppose this patient is for Whipple's surgery and he is hypothyroid. Patient is on oral L-thyroxine. Now, the patient will be receiving this dose on the morning of surgery. Since we have seen that since it has a long half-life of 7 days, we can afford to wait for another 2-3 days. But in surgery like Whipple surgery or a similar kind of surgery, patient is not expected to resume his oral intake within 2 to 3 days. So in that case, the same preparation can be given rectally. Now, rectally, you need to contact your hospital's pharmacy and they will prepare a suppository out of this active ingredient and then give it rectally. Or intravenous levothyroxine can be administered in a dose that is around 60 to 80% of the oral dose. So anything is possible, but make sure that the patient receives the next dose. During pregnancy, it is the threshold value for TSH is usually lower and it is trimester specific. In first trimester, it is you have to keep around 2.5 milli international units per liter. In second, it is 3 and third trimester, it is 3.5. Usually, we aim for around 4 to 6. And the drug of choice is PTU, propyl thiouracil, because of its less teratogenicity. Now we go to the other extreme, that is hyperthyroidism, and it just stares at you. Again, let me tell you, this is at the other extreme. All patients may not be so. This is typically Graves' disease. But usually these are the patients. It is possible to miss out the hypothyroid patient, but not possible to miss out on hyperthyroid patient. They will typically be anxious, sleepless. They will have increased appetite, weight loss, heat intolerance. They have moist and warm skin. So one handshake will give you the diagnosis, those typically moist hands. There will be tremors, tachycardia, and hyperdefecation. The frequency increases. Therefore, there is malabsorption and irregular menses. Now, what clinical effects they have on perioperative outcome? It is exactly the opposite. They have increased heart rate and increased contractility. So the cardiac output increases by as much as 50 to 300%. They have reduced SVR and wide pulse pressure. They are very prone to develop arrhythmias and they are typically atrial type. So The difference between the subclinical hypo and hyperthyroidism is in subclinical hyperthyroidism, it is still possible to get atrial ectopics. It is common in around 10 to 15% to have atrial ectopics in subclinical variety. They can have cardiovascular collapse, they have fever, confusion. The dyspnea can be because of increased oxygen consumption, CO2 production, and respiratory muscle weakness. There is increased calorigenesis and increased gut motility. So again, what are the rules for hyperthyroidism? Suppose this patient comes for, it is subclinical hyperthyroidism. Suppose this patient comes for, say, mastoidectomy. Now this, since it is subclinical, that means the TSH is low and the T3, T4 are normal. Patient can undergo elective or urgent surgeries. A beta blocker, however, even in subclinical variety, there is a usual practice to start beta blockers like atenolol, either non-selective like propranolol or atenolol in dose of 25 to 50 milligram daily is started in older individuals, or it is indicated in younger patients who have arrhythmias. In overt hyperthyroidism, again, elective surgery should be postponed because we know that we have to render the patient euthyroid. Till adequate control of thyroid activity, as thyroid storm can be precipitated by surgical insult in an overtly hyperthyroid patient. So normal T3 and T4 usually takes 3 to 8 weeks. So wait patiently for this much time and then only go ahead with surgery. However, if the surgery is urgent, say perforative peritonitis or intestinal obstruction, you cannot wait for that long time. Then preoperative treatment of hyperthyroidism should be initiated as soon as possible, and patient should be monitored for development of arrhythmias, congestive heart failure, and ischemia. Of course, don't forget to take high risk consent. Now, what we can do at this juncture? At this time, beta blockers are going to be our main savior. So again, tablet atenolol, 25 to 50 milligram per day, aiming at a pulse rate of 80 per minute. This is what we want. And tablet propranolol also can be given. Then thionamides are started, but usually the effect is, it takes 3 to 8 weeks, but nevertheless start the therapy. Methimazole also can be started, but I would suggest propyl thiouracil in the dose of 100 to 150. Why? PTU over methimazole? Because they also block the peripheral conversion of T4 to T3. The action of hyperthyroidism are because of the T3, which is more active participant than T4. And once you block this T4 to T3 conversion, half the battle is won. So beta blockers are used to counteract the sympathetic or hyperactivity and control the manifestations of hyperthyroidism. It is useful when urgent surgery is required and insufficient time to render the patient euthyroid. It is commonly used or non-selective. This we have already gone through. Intravenously, if you feel that on table the patient needs, either you can give through RT if that is allowed, or you can give intravenous preparations like propranolol or metoprolol. Calcium channel blockers also can be given. The treatment continues. Now, entire this treatment is to be given when suppose the patient is undergoing surgery, and if you feel that suddenly the patient has developed tachycardia, suddenly you see that the EtCO2 value is increasing, suddenly you see that the patient is developing arrhythmias, or you are suspecting thyroid storm, then you can immediately start all this treatment. After you start the antithyroid drugs, after 1 to 2 hours, you can start Lugol's iodine or saturated solution of potassium iodide. Why after that? Because iodine reduces the release of hormones. It does not stop the synthesis of hormones. So if you stop the release and where the synthesis continues unabated, then it will cause severe, it will increase the level of hormones. So that we don't want. And calcium channel blockers also can be given. Even glucocorticoids will have a major role. because they also prevent peripheral conversion of T4 to T3. So one can give hydrocortisone and dexamethasone in these patients. Now, how anesthesia management has to differ? Make sure that the patient is euthyroid for an elective surgery. Give morning dose of anti-thyroid medicines. For hypothyroid, how we gave the thyroxine dose. Similarly, we give anti-thyroid medicine. Many people, especially senior people, timers, they used to use thiopentone sodium, saying that it has good anti-thyroid property. So that would be then the induction agent of choice, and this is usually, I think, they expect in exams also. Here you have to see that the metabolism of all drugs is enhanced during hyperthyroidism. So you may require higher dose, you may require frequent top-ups, and be aware that the toxic metabolites which are produced by metabolism of few of the drugs may also cause problem. Use EtCO2 and temperature in the monitoring. Look for tachycardia, hypertension, arrhythmias, and hyperthermia. Patient should be monitored in the intra and post-operative period, as it is very vulnerable to develop thyroid storm. Patient can also possibly develop congestive heart failure, angina, and arrhythmias. So be ready, continue the monitoring. And lastly, there is another entity, euthyroid 6 syndrome. So patients with non-thyroid systemic disease often have abnormally low thyroid hormone level, which may not be clinically significant. This we have seen in our surgical post-surgery ICU. And many of the times who are recovering still in convalescence period. And we send their TFTs and we invariably find that the TFTs are low. That is actually there is nothing wrong with the patient. And initially we did consult the endocrinologist whether any supplementation is required. So they confirmed that it is not necessary. As soon as the patient recovers from the effect of surgery or the disease, then immediately everything will fall in place. So it is not needed in non-thyroid illnesses. So to summarize, routine preoperative thyroid function testing is not recommended for patients with no history suggestive of thyroid dysfunction. So routine screening is out. But those who have signs and symptoms suggestive of thyroid dysfunction, TFTs should be checked. Ideally TSH and free T4. Always wait for euthyroid state prior to any elective surgery. For emergency surgery, start treatment as soon as the diagnosis is made. Expect and explain the likely complications. Thyroid medications as well as the anti-thyroid drugs can be given through RT, if not rectally, if not IV, and symptomatic treatment to tide over the crisis like beta blockers and steroids, any other drugs, tepid sponging, etc. should be continued. Otherwise, it is an extremely roller coaster ride, but you can control the situation if taken good precautions. Thank you, all of you.
Excellent. Madam, am I audible?
Yes, madam, you can stop your screen sharing.
Amla, madam?
Yeah, I'm trying to press that. Yeah.
Yeah.
Excellent presentation and very informative lecture given by Amla, madam. Many queries were coming in our mind, and that got cleared by your lectures through your slides. You have highlighted many important points like whom to call primary or secondary hypo or hyperthyroidism, when to repeat thyroid function tests when patients with known thyroid disorder comes to us, then subclinical hypothyroidism, mild, moderate, severe, how to categorize them. And one important thing is rectal administration of thyroxine. You mentioned about mention it in your slide. That is very interesting. And the starting of beta blockers in subclinical hyperthyroidism is also very useful point for us.
Yeah.
There are some questions in the chat box.
Yeah.
So one question is how much time it will take to become euthyroid after starting optimum dose of thyroxine?
Yeah, it usually takes 6 to 8 weeks.
Okay, okay, nice. And second question, above which level of TSH thyroxine is advisable?
Sorry, I didn't get above.
Above which level of TSH thyroxine is advisable? When to start thyroxine?
Okay. So rather than going with TSH, see also whether T3 and T4 are low. Because if only TSH is high, you need not start. But when T3 and T4 also they are low, at that time you start.
Many times,
Means
madam.
Suppose TSH is 10. If the patient is symptomatic, you start thyroxine. But if the patient is not symptomatic, you can afford to wait and repeat the TFTs after 3 weeks. If after 3 weeks, says either the T3, T4 are reduced further, in that case, you know that now you are going towards the hypothyroidism state and the TSH will start increasing. At this time, you can afford to get just plain TSH level of say 7 to 10 units with normal T3 and free T4. At that time, you can afford to wait for 3 weeks and repeat the TSH level.
It is said that, madam, TSH level up to 20 also we can accept the patient if T3, T4 are normal.
If T3 and T4 are normal. Rather, T3 and free T4 are normal, then you can afford to wait.
Okay.
Madam, for pregnant ladies, the criteria will be same or you introduce
No. So that I mentioned that you'd accept little lower and it has to change according to the trimester. In first trimester, you accept a TSH level of 2.5 means at that level, if it goes above that, then you are cautious and then you may have to start the patient on thyroxine.
One question, madam. Nowadays, many known patients of hypothyroidism, they are on thyroxine medication. They come for surgery and they are taking thyroxine since long time. And at that time, when we check for the thyroid function test, TSH, T3, T4 are normal, but TSH comes 0.02, 0.03 like. So at that time, how should we proceed?
Yeah, that same question I had asked our endocrinologist. So this is regarding our actually, I mean, I can relate with you because we are also facing the same problem. So
Yes.
what he says is if the free T4, they give lot of importance to free T4. And if free T4 is normal, you can go ahead because TSH little lags behind. The time required for TSH to come back to normal is little later than that of free T4. So if free T4 is normal, that you should concentrate on and then you can go ahead with surgery. That is the answer that he had given me.
Okay. And role of beta blocker in such cases, can we start because TSH is low?
Sorry?
Hello, madam. Can beta blocker can be started in such cases in low TSH
But
patients on
basically T3, T4 should be high, no?
here in such cases T3, T4 are normal. TSH is only low.
Yeah. So this is the variety of that subclinical.
Okay,
Remember?
yes.
And in that case, young patient or older, I mean, young patient with atrial extrasystoles or old patient, you can start small dose of beta blocker.
No, madam, those patients taking antithyroid, these patients having low TSH in this category, shall with normal T3, T4, shall we start?
No need.
That is my query, madam.
Yeah. No.
Okay. Okay. I think
questions are
Madam, may I ask one? Sangeeta, madam?
I think
all
the
yes.
questions are over.
There are no
Amla?
questions in chat box.
Okay.
How many patients, madam, you come across the crisis of thyroid? now?
One long back in Sion Hospital, I was transferred to Sion Hospital. In between, one patient we had, So in
Yes.
say 12, 13 years back. So that patient started, that's why I commented on that. He started
Yeah.
there was tachycardia. I mean, there can be many reasons of tachycardia. So we gave little top of increase the dose and all. Then everybody thought he's little plethoric also, his hands. Then CO2 was rising. So at that time we saw probably soda lime is exhausted. I mean, we were ruling out all the possibilities in that. And then we realized probably we are, dealing with this. So immediately we gave whatever was available. I mean, PTU was not immediately available. Neomercazole was available, so that we gave 6 tablets. And then anyway, you are supposed to put RT in these patients. So it is easy to,
Yeah.
first we gave stomach wash till we assembled all the drug. So stomach wash with cold saline. And then we
Cold saline.
gave these drugs and then steroids and beta blockers. Then we
Okay.
shifted the patient on ventilator, but we could, I mean, recover the patient recovered after say 6 to 8 hours. That picking up that point is very important when all this is happening.
Yeah. And first we think of a very common causes all around, and then we
Yeah.
look for
So
for
exhausted
that.
soda lime was the
Thank
first thing which came in my mind because tachycardia, and we looked
you.
for a stuck expiratory valve. Yeah, because the patient was on paper euthyroid.
Yeah.
But the patient was for thyroid surgery, and during that, even handling of the thyroid gland during surgery, probably I don't know whether that released the hormones, and that's why the patient went in sudden hyperthyroidism on table.
Thank you, ma'am. Thank you. It was very nice talk, ma'am. Thank you.
It shows that, madam, you are a hardcore teacher.
Yes,
Yeah.
yes.
Everyone has witnessed.
Yeah.
Now, coming to an end of this session, Supriya, over
Yeah.
to you.
Yes, thank you so much, ma'am. It's
Thank you,
always
madam.
been pleasure to listen from you, and everyone has experienced that. It was really great academic feast to all of us. Now we have come to the end of the session, that is Thanksgiving. Today is a great day for all AA members, that launching of our logo, and
Yeah.
really great.
Congratulations.
Yes, thank you so much, ma'am. And it was a really great academic feast to all of us. We enjoyed a lot. So many people have joined through the Zoom link, and many people have joined through the YouTube link also. So I especially want to thank Dr. Tivaskar sir, Dr. Meenakshi Sundaram sir, and Dr. Amla Pudalkar madam for accepting our invitation and sparing their time with us, and sharing their valuable knowledge with all of us. I want to thank Dr. Balaji Asegaonkar sir, President of SAMS, Dr. Rajesh Tagadpalli sir, Secretary of SAMS, and all SAMS office bearer for providing us this platform to conduct our webinar. Our webinar is accredited by one MMC credit point. So I also want to thank Dr. Babasaheb Ambedkar Medical Research Society, who helped us in getting us the accredited points. I also want to thank all our delegates, our viewers who have joined in lots of numbers and participated actively in the webinar, and clearing their doubts with all the enthusiasm with their coming up with their queries. And lastly, I want to thank all my AA members with their continuous efforts and active participation to make this webinar happen. And thank you all. I declare this webinar is ended over here, and we will definitely meet again. Thank you. Thank you so much, and good night.
Yeah, madam.
Thank you,
Also,
everyone,
thank
and
you.
good night.
Thank you, everyone.
Person, they were, yeah.
Thank you.
Mr.
Thank you.
Ganesh, thank you very much.
Good night.